I am good to start. Give me one sec, Jamie. Make sure I have my notes available. All right, yep, we are good to go. Welcome everyone. I'm going to call the meeting to order. As we call this meeting order, I want to just welcome all the NAC members, participants, and guests to this NAC meeting. Remind everyone that, as you saw on the Zoom notification, this event is being recorded. Will be posted to our website once it's available. Closed captioning is available for this meeting. If you need closed captioning, click the appropriate icon at the bottom of your screen. With that, let's move on to introduction of a really nice cohort of new members. And so let's start off with that. I'm gonna run down the list in alphabetical order of our new members and ask that each of you share briefly who you are, where you work, who you work with, and then we'll move on to the broader introductions. So let's start with the introductions of the new members, and the first, yep, done that. The first one, yes, thank you. We'll go to is Peter Engood. So Peter, let's start with you on the intros.
Great. Hi, everybody, and thank you much for the opportunity to be on this group. Very much a privilege. Peter Engood, President and CEO for the American Association for Physician Leadership, a 50-year-old organization that is, as its name implied, focused in on physician leadership, but we're gradually expanding, diversifying our programs, products, and services, and going into the international space. Personally, I'm a surgeon by background training, spent a lot of years in academics, and then was fortunate enough to be the first chief patient safety officer at the Joint Commission, did a lot of work with the World Health Organization in patient safety, and then was a senior advisor to NQF on patient safety as well. So thank you so much.
Thank you, Peter. Mason, you're next.
Thank you, Edmondo. Good morning, everyone. My name is Mason Emmert, and I currently serve as the tribal epidemiologist for the Choctaw Nation of Oklahoma. In my role, I'm involved with our public health department and in the Choctaw Nation Health Service Authority healthcare system, where we oversee the healthcare needs for Native Americans across our rural reservation in Southeast Oklahoma. I appreciate the opportunity to be here and look forward to working with you all.
Awesome. Thanks, Mason. Sharon, you're up.
Hi, I'm Sharon Hickman. I have my own consulting company. I've been doing this for about a year, where I do management consulting as well as work with healthcare organizations on how to drive reliability across the balanced scorecard. My background is industrial and systems engineering. I have worked for for-profit, nonprofit, academic healthcare systems, doing financial operational improvement activities, as well as quality and safety improvement activities. I appreciate being a part of the committee. Thank you.
Awesome. Thanks, Sharon. Sunil.
Hi, good morning, everyone. I'm Sunil Kripalani. I'm a professor of medicine at Vanderbilt University Medical Center. Clinically, I practice as an academic hospitalist, and I also direct our Center for Health Services Research at Vanderbilt, as well as our academic activities around dissemination and implementation research. I've benefited from being an AHRQ grantee over the years. My research is focused on health literacy, medication safety, medication reconciliation specifically, and I've also enjoyed being part of one of the AHRQ study sections. Honored to be joining the NAC and getting to know you all.
Thank you, Sunil. Carrie, you're up.
Good morning. My name is Carrie Levy. I'm at the University of Colorado, where we currently have several feet of snow this morning. Very exciting. And I am a geriatrician and palliative care specialist. I'm the director of our multi-center disciplinary, we start multidisciplinary center on aging, and then also division head of geriatric medicine at the university. My research focuses on models of care for older adults and seriously ill individuals.
Thank you, Carrie. Mary Beth.
Hi, I'm Mary Beth Flynn Makich. I am also at University of Colorado at the College of Nursing. I am a professor at the College of Nursing, and I also lead the APRN clinical nurse specialist track there. I'm also a research scientist, a nurse research scientist in acute and critical care at Denver Health and Hospital Systems, which is a safety net hospital within the Denver metro area. I am incredibly honored to be as part of this committee. And I think I mentioned I'm a nurse. My background is acute and critical care, predominantly critical care is my nursing practice expertise.
Thank you, Mary Beth. Michael, you're up. I see him. Maybe he's not back yet. I see him on, but I don't see him on video. Oh wait, there he is.
All right, sorry about that. When I joined, it did not let me be a panelist. I'm Michael Millinson. I'm a self-employed consultant out of the Chicago area. I left journalism 30 years ago to be a researcher, an activist, a consultant, and a writer, all about making healthcare better, safer, patient-centered, and having the best consistent use of digital health information, which, you know, we had computers in 1997, as I recall. So I'm delighted to be part of the group.
Okay, thanks, Michael. Mario, you're up.
Hi, I'm Mario Molina. I'm a physician by training. Have spent over 30 years in Medicaid managed care, ran a large health plan. Currently, I'm chairman of the board of the United States of Care. I serve on the boards of the University of Chicago Medical Center, Johns Hopkins Medicine, and I'm a member of the board of the Johns Hopkins Health Plan. And I sit on the board of the National Museum of the American Latino for the Smithsonian.
Thank you, Mario. So that's welcome to our 8 new members to the NAC. As you can see, it's you know, as the broader group can see, we've got a really great and diverse group of new members coming in to join a really great and diverse group of current members. And so really just want to welcome you all here. And speaking of those current members, I'm going to kind of just walk through my Zoom list here and call out the current NAC members as well. So let me as I walk through this, Zhaji, I see you first.
I'm Jiajie Zhang. I'm the Dean of the McWilliams School of Biomedical Informatics at UT Health Houston. We have 3 academic departments. One is AI and data science. Another one is the clinical health informatics. A third one is bioinformatics system medicine.
Thank you, Zhaji. Cincy.
Hi, I'm Cincy Hernandez-Cancio. My pronouns are she, her, and ella. I am the Vice President for Health Justice at the National Partnership for Women and Families, which is a 50-plus-year-old, initially founded as a women's rights organization, the Women's Legal Defense Fund. And we are very focused on health equity in our health justice work around system transformation, maternal health and reproductive health and rights. And our organization also works on economic justice issues like such as paid leave and those kind of issues as well. I'm very excited to be part of this. I've been on several different advisories, including for PCORI in the past, and very excited for this conversation. Thank you.
Thanks, Cincy. Just going to keep walking through here. Liz.
Good morning. My name is Liz Mort, and I'm the former Senior Vice President of Quality and Safety at Mass General Hospital, part of Mass General Brigham here in the Boston area. And I currently am a primary care physician and faculty at Harvard in healthcare policy and Department of Medicine, do research in patient safety and teach in one of the Harvard master's programs. And this is my 1-year anniversary. It's really nice to meet all the new members.
Congrats on 1 year. David, you're up.
I'm David Ash. I am the Senior Vice President of the University of Pennsylvania and a health services researcher and general internist. This is also my 1-year anniversary.
Congrats on the 1 years. Call them out. Al.
Good morning, everyone. Al Carter. I am the Executive Director, CEO of the National Association of Boards of Pharmacy, where our membership includes all 50 state boards of pharmacy and the 10 Canadian provinces. Our mission and focus is really at protecting public health, and so we work with the boards to provide tools and resources in connection with agencies to help them use those resources to protect public health in their state. And I am also serving my 1-year anniversary. So
There it is.
good morning, everyone.
Thanks, Al. Come on.
Good morning, everyone. Welcome to the new NAC members. My name is Komal Bajaj. I'm an OBGYN geneticist. I serve as Chief Quality Officer for a couple of hospitals in the Bronx that are part of the municipal health system for New York City. And I'm a professor of OBGYN at Albert Einstein College of Medicine.
Thank you. And Kaden.
Hi, good morning, everyone. Kanan Brahmar. I'm a pulmonary critical care and a sleep medicine physician at Mayo Clinic in Rochester, Minnesota. Currently serve as Enterprise Patient Safety and Mortality Officer. Welcome to all the new NAC members.
Thank you all. Did I miss any NAC members? Okay. What I'm going to do is call out, I'm just going to take attendance. Well, no, we have new members. Actually, for the ex officio, I actually want you guys to also introduce yourselves. We got new members. We kind of need to just engage around who is in this meeting, including the ex officio members. So let me walk through my ex officio list and see who I've got represented here.
You have Gina with her hand up.
Yeah, and I see Gina. Go ahead, Gina.
Wanted to introduce myself quickly. Gina Reyes. I'm the Director for Clinical Transformation Quality at a health plan in New Jersey. I'm a registered nurse by training. My role focused primarily on population health and helping practices with transformation in the value-based care space.
Thanks, Gina. Sorry, you were on my second page. So, but I opened it up. So apologies for missing you. All right, let me look at any other NAC members that I missed before I get to ex officio. Okay, thanks. All right, so the first ex officio I see is David Hunt.
Hi, I'm David Hunt. I'm a general surgeon and medical director of patient safety at ONC.
So thank you, Deborah.
Hey, Deb Howery. I'm the Chief Medical Officer at CDC and an ER doc.
Outstanding. Let me see here. Still scanning. I think that's it on ex officio. Am I missing ex officio members?
Sherry Ling is joining, but she's not on yet.
Yeah, we had Sherry on the in the pre-work. So so we'll get her when she gets back on. No, she was at a meeting. Excuse me, she was at another meeting. All right. So with that, I think we're good. We'll get introductions to the staff as we go through the meeting. So you'll start to meet the staff over time. So that's good on that. And so attendance has been taken. So just a little bit of housekeeping on the meeting itself. So during the meeting, you can the members who've been elevated to kind of to be able to engage with chat can chat internally. But remember that the public doesn't see the chat. So if you have internal chats, you actually have to bring it out if you want it to be part of the overall discourse. For members of the public, you can make a comment at any time by emailing the comment to National Advisory Council at ahrq.hhs.gov. A member of our team will post it in the chat for all of us to see. Put in the subject line real-time post. Right, so this is for commenting in real time on the conversation that we're having. We will also have our standard open public comment period. That's from 3:30 to 3:45 Eastern. If you would like to make a brief comment, and brief means no more than 3 minutes, to the council, then send an email to that same email address, nationaladvisorycouncil@ahrq.hhs.gov. Subject line on this one, though, is public comment. And please submit those emails by no later than 2 p.m. Eastern today. And for both of those, for real-time posts as well as for public comment, the NAC members are not to respond directly to those comments. You know, and then when you're doing public comment, just make sure that you keep the public comments professional and pointed toward the relevant topic. So the first order of business, I don't see any questions yet. So the first order of business will be to approve the minutes. Any changes or edits to the draft minutes that were sent ahead of time for council members to review? I don't see any, so do I hear a motion?
So moved.
And a second, I see a second from Kamal. So it's been moved and seconded. Any concerns, questions about approving those? Right, okay, so if all those in favor, do a little raised hand on your Zoom. Yep, that's it, that works. You could also have hit the raise hand symbol on the bottom of the Zoom, but that's fine. I saw all your hands. Thank you. So the minutes have been approved. So let's actually pop up on the screen the agenda for today so we can walk through it. Perfect. Okay. First bullet has been done. We will first, as always, we'll hear from our director and get some highlights. And then we'll spend some time, and we've had some discussions around this, so we'll spend some time and get some updates from the SNAC that is focused on P-Corp Trust Fund investments. Some really interesting updates there. Had a good meeting in February, so we'll hear that. We'll talk next about the 20th anniversary of digital healthcare. And we had some pre-discussion on that topic as well as the next topic, which will after digital healthcare will be the National Action Alliance for Patient and Work for Safety and Diagnostic Excellence. So we'll get an update there and being able to engage with staff around that topic. As I mentioned, we'll have public comment and then we'll wrap up. So that is the aggressive agenda for this meeting. With that, let's turn it over to our director, Dr. Bob Valdez, and let's get into the director highlights.
Thanks very much, everyone. And thanks for joining us, both the council and the public who are joining us online. Next slide, please. As I usually like to do, I like to remind people of AHRQ's unique federal role in the healthcare space. Our job is really making healthcare for the 21st century a reality for all Americans, and to remember that we do that in multiple pathways. Our colleagues and partners at NIH, ARPA-H, FDA, and focus on really trying to understand the pathologies. But biomedical discoveries really are definitely necessary, but they're not sufficient. And so AHRQ was set up to really focus on healthcare improvement, to generate the evidence, the scientific evidence that's necessary to move us forward, to disseminate and help implement really the synthesis of that evidence into actionable knowledge, and to improve primary care and partner with, in particular, our patients, and of course, the private sector that provides most of the healthcare in the United States. As I like to say, AHRQ should be thought of as to healthcare systems, as CDC is often thought of for providing the evidence and knowledge for public health systems. Next slide, please. What I'd like to do for this update is really talk a little bit about the 24 budget, review what the president has proposed as our 25 budget request, and then talk a little bit about our 25th anniversary. As you'll see on this slide, we have a new logo up there saying the 25th anniversary of AHRQ, and I'd like to tell you a little bit more about what we have planned for this year. Next slide, please. This looks like a previous one slide too many. Is there a previous slide? Nope. Okay. Well, I guess there we go. I'll start with the 25 budget then. As you know, I put forth a pretty aggressive set of objectives and some example strategies that I'll share with you that have been driving our work since 2022 through, which should take us through 2026 and beyond. And that is the first objective I put forward to us was really trying to improve local healthcare systems performance with some strategies that are focused on reducing fragmentation, which is the bane of our system, aligning the financial incentives that our health systems operate through, and really reducing the inequities that we see in our healthcare, vanquishing the unequal treatment that has been historically documented for decades. The second objective is really expanding access to services in a way that is responsive to the consumer experience and improves the consumer experience with healthcare. And of late, we've been talking about how we need to think about measuring customer experience in a new age. And I'll be talking more about that later, and you'll be hearing more about that as well. Another strategy is really about integrating and bringing together the mental health and behavioral health services, which operate under a completely different system, together with our physical health system, with a real focus on integrating mental health and behavioral health into primary care. And the last objective is really recognizing the need to improve our health system's delivery's resilience to the vast number of threats to its ability to function, particularly under climate change conditions that bring more storms and other things. The president's 25 proposal has really made investments in our core areas of health services research, improving care delivery and quality, and in particular, the collection of data and analytic resources that are necessary for our health policy makers to really make data-driven decisions about how our local markets operate. We've currently been slated for a request of $387.3 million to the Congress, which would be an increase of about $14 million over the 23 enacted funds. We're currently operating under a continuing resolution in 2024 at that current level of 2023. Next slide, please. The federal budget in 25 highlights some major priorities. The medical expenditure panel survey, which I mentioned earlier, was really about the ability for state and federal policymakers to have the data that's necessary to make data-driven decisions. We have also seen an increase investment request for the U.S. Preventive Services Task Force, which is an autonomous group of volunteer experts on preventive services that are housed within the Agency for Healthcare Research and Quality. This will be the first major increase for the task force in over a dozen years and is desperately necessary for it to do its work appropriately. They also are one of our prime consumers for the evidence work that we do in the department or in the agency. And we look forward to working with that task force as they help us also drive the innovation that's necessary for synthesizing the vast amount of research that's done in the country. We also find an increase of $55.5 million investment in investigator-initiated health services research. Helps us translate really findings that can be turned into actionable knowledge and tools that AHRQ makes available to our healthcare systems and clinicians. We've started as a part of this work in improving primary care and care for tens of millions of people who experience the lasting effects of COVID, known as long COVID. We've created a network that will continue on, and that is located in 9 different parts of the country, giving us a national reach in this issue, and is designed to provide us with the evidence that we need to know for providing better care for people, while our colleagues at NIH and FDA work on trying to find treatments and cures that potentially can find their way into the marketplace. Next slide, please. We also continue our work in patient safety, and we have a request in for $89.6 million. We have a $20 million diagnostic safety work, which you'll hear more about during the course of this discussion. We have a $2 million investment in a Center for Primary Care Research to really focus on moving the ball forward and improving primary care in our nation. And lastly, we are focused on trying to address the opioid epidemic in our country by looking at other ways in which primary care and behavioral health services can be integrated and treatment made available. That investment is slated for about $3 million request. And we've also requested $77.7 million to support the dedicated staff that you'll hear from today, who help us move forward the work of AHRQ. Next slide, please. Well, AHRQ is celebrating 35 years, and in 1989, the National Center for Health Services Research and Healthcare Technology Assessment was elevated to independent science agency status within the Department of Health and Human Services. What this recognized was really 2 other paths for making medical progress. As I mentioned to you at the beginning of my comments, there are really 3 paths to making medical progress. 2 of those paths reside within AHRQ. The second is really understanding how new technologies and new materials find their way into current protocols and current treatment. And the third is really about clinical learning in a systematic way, which is what health services research was designed to do. The agency was reauthorized under the title of Agency for Health Services Research and Healthcare Technology Assessment, which really established the fact that health services research was an essential part of improving healthcare delivery. For those of you involved in healthcare management activities, you know that trying to drive improvements is a continuous effort and requires data collection, analysis, and a culture that looks to innovation to improve the quality of care that you provide as a product to your customers. And lastly, we were reauthorized as the Agency for Healthcare Research and Quality, which recognized that real-world research was truly needed to improve care, and in particular primary care. And so it also became the home for the Preventive Services Task Force. We celebrate this long history in this effort to really bring the other 2 strands of medical progress together. And next slide, please. We during the celebration, we're created an alumni group. We invite all of you who have previously been associated with AHRQ, either on the advisory council or as members of AHRQ's larger external research community, to join us on LinkedIn. It'll offer an opportunity for us to engage in better communication and collaborations. I'd like to thank our previous directors, many of whom are still with us, and for their leadership and the successes that they made during the time that they led this agency. And we'll be inaugurating a Hall of Fame really for AHRQ, because there are great achievements that need to be recognized and continually recognized. Next slide, please. We have some other milestones at AHRQ. The Preventive Services Task Force, as I said, is an autonomous group that pre-existed AHRQ. They're celebrating their 40th anniversary, and we're really proud to be the home of the U.S. Preventative Services Task Force and to support the work that they've been doing all these years. Today, you'll also hear about AHRQ's digital healthcare research program, which is celebrating 20 years. And without further ado, I think we should move on so that you can hear more about these.
Thanks, Bob. But before we jump into the snack, I did want to open it up to see if there are any questions for Bob and his director highlights. If you do have any questions, you can kind of raise your hand, and I'll catch you as you raise your hand. You can also say you have a question in chat, and they can call on you that way. So, any questions or comments? Well, I'll just say that as people kind of gather their thoughts, because I kind of put them on the spot a little bit, but I'll say, Bob, that thank you for these highlights. It's really, really great work. Appreciate your aggressive approach to the budget, and really trying to get those things through. Know how much how challenging that can be, and your focus on the things that are important, including the fragmentation, which you've always highlighted. As well as taking a moment to celebrate and recognize the work over the last 35 years. I think it's really important to take that look back and see what's been accomplished, and so that we know that we have a strong foundation for which to move forward and tackle the challenges, the pressing needs that we have in front of us, including among others, as you mentioned, long COVID, and there's many others that we're going to continue to tackle and even discuss today in this meeting. So thank you for that and your leadership of these efforts and of your team.
Thanks very much, Edmundo. I appreciate that, and really addressing and reducing fragmentation also recognizes the importance for improving patient and workforce safety. And I want to make sure that the workforce part of the question isn't ignored, because it also is a real contributor to the burnout that we see in our among our colleagues, who some of whom have remained providing services, and others who have decided it's time to hang up the gloves and do something else. Yeah. And we really, as a society, can't afford that.
Yeah, no, spot on. And as I was popping through some of the sessions this morning, that did get called out as well. So I'm excited to see how that gets pulled into the conversation today. Let me just do a quick scan on chat before I move on. Got it. Oh, thanks, Kamal. So a question Dr. Bajaj has is in the spirit of kind of reflection and celebration, do you all have, and maybe you don't have them on like right in hand, but it come bring it back to the council, some insights into the reach that AHRQ has had over the years, number of downloads, citations, dollars, kind of distributed from a research funding perspective. Any of those cumulative summary stats that'll give us a sense of the quantitative impact that AHRQ has had?
Well, we have had an incredible amount of, particularly since we've gone online, we've had an incredible amount of downloads, for example, of some of the tools that we have been putting forward. I know that later on, Craig will be addressing you about our patient safety work, and part of that work has been Team Steps, which is now in Team Steps 3.0, and I've been pushing out on LinkedIn. We have a pocket guide for people who want to use Team Steps 3.0, and so I encourage everybody to go on to your favorite app store and download that. We've also put out a tool for consumers to prepare for their visits with their clinicians. It's called Question Builder, and it was in the top 10 of For example, the App Store's health division. We're working to upgrade that and make that a much more useful tool. And we have, I think that gives you some idea that there's both the public aspect as well as our clinical leaders who have reached out for services. We also have tools that most healthcare trustees, healthcare system trustees have used that may not even know that they're an AHRQ tool called Candor, which is used by the vast majority of health systems leaders that I've spoken to over the last 5-6 years now. As I was doing more work on governance of health systems in the private sector before joining AHRQ, I was surprised that Candor's has really reached into the entire U.S. healthcare system's governance bodies.
Awesome. Thanks for that. And it sounds like the staff has also responded and says that they'll try to pull some of that quantitative data together to move forward. So thank you for that. Let's move forward a few minutes behind as we're tracking the agenda timing. So I did want to go ahead and bring in Karen Rhodes, who's Chief Implementation Officer for AHRQ, to give us the update on the SNAC for the PCOR Trust Fund investments. Karen, take it away.
Hello, everyone. Nice to see you. Hi. I am not going to do a full update on the PCOR Trust Fund. I'll be doing that on April 16th for new members. And everyone is welcome to join there. But this is really a very brief update on the last SNAC meeting. The SNAC, which is a subcommittee of the NAC for purposes of making recommendations to AHRQ on our PCOR Trust Fund investments. So you'll recall, so it's been a 2-year venture, and in the November of 23, they provided recommendations in the following categories, and a full report was sent. There was one more meeting on February 13th that where they sort of went over their other recommendations and heard about 2 brand new programs that had not been previously public, one in the area of training and the other is our multi-stakeholder intervention, our multi-state healthcare extension program, our largest D&I that will become a landmark program for AHRQ. So this was their opportunity to hear about it, and they made recommendations to the NAC, and recommendations to the NAC become voted on by this group and then become recommendations to the director. So the ones that were previously approved really focused on primary care transformation, health equity, specifically building community capacity and creating incentives around health equity, and advancing stakeholder engagement and partnership models. So those are the ones that you approved before, and there's a full report on this. Then they made the following recommendations as they heard about the 2 new programs. So I want to go first to the area of training. Next slide. So AHRQ has recently co-funded with PCORI, an embedded scientist training program that are sort of a new model that's designed to diversify the pipeline and create new opportunities, research opportunities using principles of community engagement and teaching mixed methods and implementation science and focusing on metrics that matter. So the SNAC heard about the program and said, hey, this is exactly what we recommended last year. We are really pleased with the results, but you should figure out how to do standardized evaluation of your training programs, maybe put out some toolkits. So we funded 16 of these embedded scientists training programs. And we are now moving to fund a evaluation, a learning center, a learning network, and evaluation across all of them. So that was the first program, and their recommendations really aligned with exactly what we're doing. So the next program that they heard of, which is, by the way, next slide, is AHRQ's multi-state healthcare extension program, which is going to be a substantial investment, funding up to 15 programs across all of the HHS regions. So this is still in final stages of, and that the notice of funding opportunities will be released this spring, soon, very soon. But they got to hear about it from the team that is building out the NOFOs, and they made the following recommendations. Work closely with CMS and state Medicaid programs in each area. They felt that having Medicaid at the table was foundational for the programs. They pointed out there's multiple initiatives in every state, and whatever topic is selected, and the first is going to be in the area of behavioral health, they should integrate across all of the federal, state level work happening in that state and make sure that it's all aligned. They recommended reducing administrative burden around data collection for the entities that are collecting data, and that the initiative should be co-created with community partners and shouldn't be a top-down, here's the evidence we would like to see implemented, but instead should be one where a multi-stakeholder council actually co-creates with the partners what their top vision priorities are, and then there's a feedback loop from the research partners to the community partners that will allow them to identify barriers and facilitators and fix any problems. So even though they didn't know the details of all of this program that are still to be released, they were very on target with a lot of exactly what is under development, I'm happy to say. They wanted the focus to be on low resource organizations, community-based organizations, and not just the usual suspects. And they wanted the funding shared equitably amongst the members of the multi-stakeholder council. And they felt that there should be room for innovation, aligned innovation that advances new integrated care models, particularly whole person care across the lifespan, which is one of our, which is our vision for the PCOR Trust Fund. So those were their recommendations from the SNAC to the program. And I think you'll see them reflected when the notice of funding opportunities are released. So finally, they reiterated, there was a, next slide, there was a discussion at the end after they'd heard from the programs, and they said, okay, but don't forget our top priorities, and these recommendations should go across all AHRQ's Peace Corps Trust Fund recommendations. And that is do more around stakeholder engagement, include patients in that. They recommended that AHRQ start an Office of Stakeholder Engagement and develop a expanded network of stakeholders that they could call upon. They said in the area of health equity, we should standardize how we're evaluating it and increase public transparency and make sure we're capturing the voice of all participants and do outreach to make sure that everyone's voice is heard. And finally, develop the metrics for a very rigorous evaluation and to hold ourselves accountable in the area of health equity and also stakeholder engagement. And then finally, we said, don't forget our top priority is that our focus the Peace Corps Trust Fund on improving, growing, developing new models of primary care. So that's where they left it. And so what we did is we took the prior report and we added an addendum, and the full report was sent ahead to everyone. I'm happy to answer questions on it, but it will be on the website and with the new addendum. And I am going to ask Jamie, if she hasn't already, to put in the snack a link to all of the background about AHRQ's Peace Corps Trust Fund investments and what we're currently investing in, our large programs, so that you can read up on it. And I look forward to answering any questions. So next, all these recommendations are ones that this group needs to sort of vote on. So I'm happy to answer questions about the recommendations, but I want to leave time for discussion. So
Yeah, that's perfect. Thanks for that overview, Karen, and summary of the updates on the recommendations. You all received the full report. NAC members received the full report in your meeting packets. I'm going to see if I can remember the page numbers. I believe it was page 35 that actually went over the meeting itself, the meeting minutes, so you can see what happened in that February meeting. And then those new recommendations start on page 17 of that report. So you have a chance to review the recommendations that Karen just summarized for you all here. So we only have a couple of minutes and we've got to get a couple of things done. So one is I want to make sure that there's room and time for questions, clarification, any comments that people might have that Karen can either answer or take in. And then we do actually have to vote on those recommendations and accept those recommendations of the SNAC to bring them in as recommendations ultimately from the NAC to the team. So let's start with questions. And first I see Michael, so go for it.
Hi, Michael Millinson. Wonderful report. I have a little bit of confusion, however. The report says that the SNAC recommends that AHRQ invest heavily in primary care transformation. And I think you were talking about that coming from the funding that would go to researchers. But in the FY 2025 budget, there's $2 million for primary care, quote unquote, revolution, which I believe buys lunch for a private equity firm. If AHRQ is going to invest heavily, shouldn't some of that money come from AHRQ as well as from researchers?
So that 2 million, and I could let Bob weigh in on that, is appropriated dollars from Congress. This is Peace Corps Trust Fund, and the
I get that.
And we have two mandates. One is training, and the other is dissemination, implementation of evidence. We have, I think you will see in the multi-state healthcare extension service that our primary focus is around an investment, is very large investment, and is largely focused on improving the way healthcare is delivered, including primary, but also the interface with health systems and specialty care.
I hear you, Michael. Clearly, the 2 million in the appropriated ask and even the trust fund dollars that we receive, which are, we get 16% of the trust fund for two missions. One is disseminating and implementing PCOR and work that has been done both by PCORI and other organizations, AHRQ, private foundations, and others into the healthcare ecosystem. And clearly there hasn't been enough of an investment in primary care nationally. And so I think as we do our work with our colleagues across the agencies, part of what we do is also partner with other agencies that have a mission in improving primary care. So most recently, we've been working with CMS in their CMMI program to influence their primary care initiative, which is funded under that program. So while our piece of it and our funding is relatively small, we are in many ways a consulting firm within the department for other agencies' activities, and have been providing the evidence necessary to try to make those initiatives more effective and more useful.
Great, thank you.
Thanks. Liz, you're up.
Karen, thank you for that great report. Congratulations. A question for my clarification on your scope. When you're talking about primary care delivery and improvement, are you embracing and looking at the new entrants, as they're called, retail-based primary care, the use of public health services for primary care, other service industries that are getting in on the opportunity because of the shortages from the traditional healthcare delivery system? Are you embracing that sort of full span of players in this work?
So, yes, we're interested in new models, specifically around team-based models. We are not researching those directly right now through the PCOR Trust Fund, but our training programs could do that. And that's why we've left it open as you train the next generation of health services researchers with a focus on the things that AHRQ cares about, like primary care, like health equity, and we encourage them, and we make all of our tools and strategies and evidence available to them. So I would say everything is within scope. We want to improve the way healthcare is delivered for the American public, and it's a big job. And we're lifting the weight we can lift to get us there.
Thanks, Karen. I just think for researchers to have a roadmap and tools and ways to facilitate engaging in areas of the healthcare delivery system that are now much broader and include lots of different stakeholders is important, because that's where it's happening. That's where care is being delivered. So we have to make sure we're understanding the implications with the same rigor that we've applied to our traditional healthcare delivery system. So thank you for considering that.
Yeah, great points, Liz. Any other questions or comments? This is one of the important roles and functions of the NAC, is to spin up these subcommittees, go deep on a topic, and come back with recommendations that'll help the director and the team move forward. So let's make sure, we want to make sure we give this appropriate time and attention. Check the chat real quick. So seeing no other questions or comments, with that, I will entertain a motion to approve the recommendations of the SNAC for the PCOR Trust Fund investment.
So moved.
I second.
Moved and seconded. Any questions about that?
I just want to make
wait, I'm sorry.
I just want to
something.
make a comment to Karen in that when you focus on this, and I completely agree with all these suggestions, and it got brought up during our conversation today, just with the health equity piece and your usual individuals or usual institutions that get grants, how can we, just a way to figure out how they can connect with those that don't have those same services to provide a framework to allow them to be able to utilize those same type of practices. And I think you all will do that, but just keep that in mind. That's all I would say.
Thank you.
Yes, no, great call out, and that will be incorporated into our recommendations. The motion to approve has been submitted and seconded. All those in favor of approving these recommendations, please raise your hand. Reviewing, looks good. Okay, those that drop your hands. Anyone who is opposed to approving these recommendations, I'd like to see you. Okay, seeing none, those recommendations have been approved, Karen.
Thank you.
With that, what we'll do is, I don't want any hangry people on this call, and for the folks on the East Coast, it is lunchtime. So, you're gonna have to do like I did in college, working in dining services. You get 15 minutes to get your food and eat it. We will be back sharp at 12:25. It's okay, you can eat while you're on the call, it's fine. But we'll be back restarting sharply at 12:25 with our next agenda topic. It was actually 12:11 when I let everyone go. I may wait a minute. Give me exactly 15 minutes. And there it is. All right, so we're back. Let's get everyone back on. Thanks for your very quick break and then turning back around and back to business. Really important, another really important topic here, which is really, we talked a little bit about it in some of our pre-sessions around digital healthcare. Really, this opportunity to both kind of celebrate and understand the opportunities around the 20th anniversary of digital healthcare. So with us to help walk us through this will be Chris Dymek, who's the Director of Division of Digital Healthcare Research in the Center for Evidence and Practice Improvement, and then Edwin Lomitan, who's the Physician and Senior Advisor for Clinical Informatics in the center. So Ed and Chris will get us through this session. And again, remember that we had some questions as part of the pre-work that we will bring in some of that discussion and conversation to this discussion here. So Chris and Ed, why don't you guys go ahead and take it away?
Thank you. So if we could have our intro slide, please. So I'm really pleased to be with you today to share some exciting news about our Digital Healthcare Research Program, or DHR program. First off, we're celebrating our 20th anniversary this year. And on the right, you'll see the terrific DHR team portrayed as already celebrating during our holiday brunch. While Ed and I are presenters on behalf of our team today, it's really the entire team that makes what we do possible, including this presentation. We'll start off by sharing some of our history so that you can gain a sense of the importance and impact of the work we've supported over the years. Next, clinical decision support, or CDS, is a large focus area for us, and we'll provide you with a look at past and present CDS accomplishments. If you could go back to the agenda slide, please. We also want to share our focus on equity and let you know about our recently developed Digital Healthcare Equity Framework and Guide. Lastly, we'll provide you with an update on what we're planning for our 20th anniversary. Next slide. Prior to formalizing health IT research as a distinct area at AHRQ in 2004, AHRQ did support early health IT R&D as noted in the journal article portrayed on the right. John Eisenberg, AHRQ's previous director, was one of the authors of this article. When I first read this article, I really came to appreciate AHRQ's long and storied history of supporting some of the earliest research and development of information technologies and informatics used to improve the safety and quality of healthcare. Noted on the left are just a few highlights of that early work. AHRQ supported the development of early automated medical record systems, Notably, we funded Dr. Morris Cullen, a physician and founder in the field of healthcare informatics, whose research at Kaiser Permanente led to one of the first computer databases for tracking patients' healthcare, an innovation that's now emulated around the world. We also supported research in computer-based monitoring of patients in critical care settings. And we supported the first implementation of a hospital-wide system that included direct physician order entry. And we designed and tested computer-aided decision-making tools that produce prompts for clinicians. And for my fellow informatics nerds in the audience, AHRQ contributed to the development of medical information standards, such as LOINC, that's still in use today. Next slide. Taking inspiration from the seminal IOM report To Err is Human, AHRQ decided that increasing health IT use to improve care was a needed focus. Dr. Carolyn Clancy led this charge. And in 2004, our founding year, the Transforming Healthcare Quality Through Information Technology grants were awarded. This was one of the first attempts by the federal government to sponsor health IT implementation and use projects in rural hospitals and community healthcare settings. Of note, in the period from 2004 through 2009, AHRQ supported foundational efforts in telehealth care with the first Project ECHO research, which demonstrated that the same level of care could be achieved in rural areas that's available in cities with specialty medical practices by bringing rural doctors and University of New Mexico disease specialists together online to co-manage chronic disease patients. AHRQ also supported early state efforts in health information exchange, which were an important precursor to the Qualified Health Information Networks, or QHINs, that the Office of the National Coordinator for Health IT is now standing up. Important CPOE and CDS efforts, which Ed will be discussing in a few minutes, were also undertaken. Next slide. During this next period, the HITECH Act of 2009 introduced incentives for EHR adoption. So with health IT use on the uptick, AHRQ focused on successful implementation of health IT. Early AHRQ-funded research in this area looked at how human factors and technology affected safety and how technology should be incorporated into workflow redesign. The Patient Protection and Affordable Care Act created the Patient-Centered Outcomes Research Trust Fund, or PCORTF, and AHRQ's mandate to implement research findings into practice via CDS. AHRQ also contributed to informing policy via the JASON studies. JASON is an independent group of elite scientists which advises the government on matters of science and technology. Members have included several Nobel Prize laureates. And for those of you who might know of him, Freeman Dyson, a noted theoretical physicist, was a JASON. AHRQ partnered with ONC and the Robert Wood Johnson Foundation to produce the 2013 and 2014 JASON studies that informed ONC policy. Specifically, the 2013 report noted that the foundation of interoperability should be an architecture based on public APIs or application programming interfaces, what we're all now adopting and working toward. The 2014 report noted that we should expand health data collection beyond what was then captured in clinical settings and EHRs to include patient-generated health data, or PGHD, and OMIC data. DHR has been supporting grants in this area beginning in the next timeframe that we'll discuss on the next slide. Next slide, please. Patient-centeredness became a goal facilitated by advances in digital technologies, such as the ubiquity of mobile computing and the use of patient portals. AHRQ realized the need to fund research into how to better use technology to collect and use PGHD and social determinants of health data to create more patient-centered care. AI also started advancing, and AHRQ once again partnered with the ONC and Robert Wood Johnson Foundation on a 2017 JASON report focused on AI in health and healthcare. JASON, back then, concluded that the broad advances in AI are significant and real. And given where we're at 7 years later, I think we'd all agree. JASON also cautioned at that time about the limitations of AI, the need for quality data, and the need to foster capabilities to capture and integrate data on environmental exposures and social behaviors in AI healthcare applications, since health outcomes are very affected by these factors. Given the exponential rise in the last year in generative AI, we're now thinking about commissioning a fourth JSON AI report to help us think about how to manage and evaluate the use of large language models in healthcare and where we need to pay attention to potential new uses of large language models. Currently, we support about 13 AI-related grants in a range of healthcare domains. Next slide. We saw that the field was moving from a focus on increasing health IT use to a focus on all things digital, beyond traditional health IT used in clinical settings. So we believed our name needed to reflect that change. And in January of 2020, next slide, please, we announced the name change from Health IT to Digital Healthcare Research. We were careful to focus on digital healthcare with an emphasis on care and included the term research in our division's name to distinguish what we did from the Office of the National Coordinator for Health IT and FDA's Digital Health Center. Our team believed that we needed a graphical way of representing what we mean by digital healthcare. So we came up with a graphic on the left of this slide that depicts digital healthcare ecosystem elements. This ecosystem includes clinical, contextual, and patient-generated data, as well as the tools used to manage and apply these data, such as advanced analytics like AI and data visualizations. The application of these data can result in knowledge which can take the form of computable clinical guidelines and decision support. Various actors within this ecosystem include providers, payers, patients, developers, vendors, researchers, and many others who create and use these resources. We're interested in how these ecosystem elements and actors can best support the quality and safety of healthcare. Next slide. At this time, we also developed a vision for the future that's based on having maximum data and knowledge liquidity so that when any of us has a healthcare need, we and our healthcare team have all relevant data about us, clinical, contextual, and patient-generated, along with all relevant current biomedical knowledge readily available at the point of care. That data and knowledge will need to be mediated by AI, however, to make it manageable. Clinical decision support plays a key delivery role in supporting our vision, and I'd like to turn over the presentation now to Ed, who manages our clinical decision support work. Ed's going to share a rich history in this area along with some new developments. Ed?
But can we pause here? Thanks, Chris. Can we just pause here for a sec? I want to make sure between Chris and Ed that I understand how you split up the presentation. So Chris, is because my understanding is there was a first section that you were going to do, second section that Ed was going to do. Have you concluded with your first section, just so I'm clear on where we are?
Yes, and then after Ed talks about the clinical decision support work, I will come back in and then, conclude with some information about our equity work as well as our 20th anniversary celebration next steps.
Got you. So let's do this. I appreciate that clarification. So let's do this. Let's take a pause here to engage the NAC around the content that you just shared with us. We did have a part where I actually want to jump in here. So we had a breakout groups earlier this morning. And I just wanted to take this time, even though I know that there's more content coming from Ed, to see if anyone from the breakout groups, especially 3 or 4, actually 4 or 3, I think it was 4, it might have been more relevant here. But either way, 3 or 4 that were talking about digital, had any thoughts or comments based on what they heard coming from Chris over the last 10 minutes or so. Go ahead, Joji.
So number one, thank you for sharing the entire history. And I was a grantee and followed this for years. So my question is, we all talk about AI and we all know it's real and it's going to be big. So is AHRQ, or especially your center, prepared to help, especially on the safety of AI products and implementations? And that can become a huge issue for acceptance and for quality control.
Yes, we are. In fact, we're thinking about how to do this more explicitly right now, but currently we also have a special emphasis notice that we can send you a link to that indicates that we're interested in safety overall. So anybody who's interested in doing some work on the safety of AI applications can respond to that special emphasis notice right now with a particular grant application if needed.
Thanks for that, Chris. Any other questions or thoughts on we got a really good chunk of the background here and some of the work that has been done and is to come. Anyone from either of the breakout groups who feel like any of the discussion that was in that group relevant to this first section that Chris just presented? This is where the two folks that you all assigned in groups 3 and 4 as your spokespeople step in if you think it's relevant. Michael, go for it.
Well, I have a question for some of my own work. I've been writing for the health policy literature for a number of years now about the use of non-HIPAA protected health data in the name of social determinants of health. And so what you have is you have major health plans, some medical centers and others scooping up data from data brokers, like where you use, what websites you use, a lot of personal information that's not HIPAA protected. They throw it through an AI algorithm, and then they use it for outreach to people for social determinants. Or in the case of medical centers, you combine it with HIPAA data. There's been nothing in the literature about this. In fact, as far as I can see, the 1 or 2 articles I've seen in the literature, there's no knowledge this is even going on extensively in the private sector. And yet it's affecting tens of millions of Americans, Medicare Advantage and otherwise. And I'm wondering whether or not this is an area that AHRQ can commission research in so we can get something in the public record on whether this use is totally wonderful. We don't need to look at the AHR anymore, has bias of its own, or maybe we could combine the two.
Probably some combination of the two will be needed down the road. And I would look to my colleague at the Office of the National Coordinator, who David, who's on this call, to think about some policy aspects that we can deal with about the use of this SDOH data that's not under HIPAA rules.
Yeah, that's right. I was looking right at David to see if you had anything you wanted to jump in on this one, Dr. Hunt.
No, but it's a very, very good point to bring up. And we've been very, very interested in the transparency of where data brokers are getting, storing, and using some of this information. But I don't have anything right now to announce. Yeah.
I'll be happy to talk with you guys offline. I'll just give you one last point. A year and a half ago, I happened to be working with a member of Congress to get into the Omnibus Appropriations Bill, a requirement that CMS look into this. And it was, 6 lines in a zillion-page bill, and somebody took it out of the conference committee. So that tells me that there are people who have an interest in non-transparency who are paying lawyers and lobbyists a lot of money to be non-transparent. So I would suggest that it would be a good place for government to tell the public that they're being monitored without their knowledge or consent.
Yeah, good call out, Michael. Al, you're up.
Thank you, and thank you, Chris, for that presentation. I think one of the things that our group really focused on, and said a little bit earlier about AI, and that everything is focused on AI. The challenge there is, how do you make sure that it is integrated, and how do we make sure that implementation can happen across all systems? And so, when we go down this path, the call out for an implementation guide or some type of manual that is defined is going to be extremely beneficial, especially to those underserved populations and those systems that wouldn't necessarily implement this otherwise. And so just some of the things to consider, in that the potential is huge here. And it is going to be something that moving forward, we will have to implement in all health systems. And we all know from EHRs that the challenges and hiccups that come with those systems. And I think AHRQ can can play a large part and a large role in making sure that there's integration and that there's implementation by providing manuals or guides to assist with that process.
I totally agree. I hear you. And we've done similar work with respect to AHR implementation, as I mentioned in some of our history. We'd love to do that with respect to implementation of AI algorithms as well.
Yeah, that's great. Cincy.
Hi, so I'm very interested in the intersection of the use of AI in healthcare and health equity. And so I know you're going to talk a little bit more about your focus on health equity later, but I specifically am trying to think it's important for us to think about how the federal government can be involved in ensuring, and I know there's already been some efforts in the space, but in ensuring, especially when it comes to the training data, what are the guardrails that need to be in place so that the existing structural inequities in the healthcare system aren't reified with AI.
Very important point, and we'll be discussing that a bit more when we talk about our equity work. Thank you for raising that.
Awesome. Let's move on. I see you, Peter. I'm going to hold just for a second, so I make sure that Ed gets a chance to walk us through part two. Your first up, though, when we come back around for our second set of questions.
Okay, great. Can you hear me okay? Thank you, Chris. Thank you, Dr. Robinson and Dr. Valdez, and to the NAC for the opportunity to present. And so in this next segment, as Chris mentioned, we're going to focus on our investments in clinical decision support, which represents a fairly large portion of our portfolio over the last 20 years. So if you could go to the next slide. We thought we'd take you down memory lane a bit. This is really a story about the people. Of course, as well as the research and the impact of that research. It's also a story about identifying challenges, trying to tackle those challenges, and identifying opportunities for what needs further exploration, as we kind of just talked about. Next slide, please. So let's start with the people. And this may seem like a long list, but actually it's much shorter than the complete list of AHRQ grantees who have made significant impact in the field of clinical decision support, or CDS, and really clinical informatics at large. I'll say if you don't see your name on here or a colleague's name on here that you feel should be, I'll apologize now. As I said, the complete list is really long, and for visual presentation purposes, we just had to limit what you see on that slide. But I do want to highlight a few from the list. So first, I'd point out Patty Brennan, who recently retired and the past director of the National Library of Medicine, the late Ida Berner, whom some of you may have known, and you may have seen our recent tribute to Ida appearing in JAMIA, celebrating her contributions to biomedical and health informatics, including decision support. Speaking of JAMIA, we also see Sue Botkin here, the current editor-in-chief of JAMIA, the Journal of the American Medical Informatics Association, and our professional society and home. Chris mentioned Dr. Morris Cullen earlier, also an AHRQ grantee, and for whom the most prestigious award that the American College of Medical Informatics gives is named. In fact, many of AHRQ grantees are also Cullen awardees. We have several past presidents of AMIA and its board of directors, such as Patty Dykes and Blackford Middleton, and the current president of AMIA, Genevieve Melton-Moe. And lastly, I'll just point out Dr. Aaron Carroll, who is the newly named president and CEO of Academy Health, an AHRQ-funded researcher specifically in the area of clinical decision support and pediatrics. Next slide, please. We wanted to highlight some of the seminal work that AHRQ-funded CDS researchers have produced. So the famous 10 Commandments paper, for example, by David Bates and Gil Cooperman and others, who named the principles we still talk about today, such as meeting user needs in real time, speed, integration into workflow, simplicity, monitoring impact, and continuing to improve. The Roadmap for National Action by Jerry Osheroff, Jonathan Teich, and others, that talks about representing decision support in standard formats, distributing clinical knowledge and decision support through services, and fully leveraging the data in EHRs and other information systems. The often cited 5 rights of CDS, where the aim of decision support is to deliver the right information to the right people, using the right formats and right channels at the right times, also attributed to Jerry Osheroff and other AHRQ-funded researchers. And that 5 rights framework really has informed how we as a program have thought about decision support. So way more than the alerts and reminders that we know get in the way of workflow, but all kinds of technologies and channels that help make the right thing to do the easy thing to do. I should also mention the role of our funded CDS researchers in education. The Clinical Informatics Study Guide, edited by Brian Dixon and JT Fennell, is a book for physicians studying for the boards in clinical informatics. In fact, John White, our former director of our division, which is called the Health IT portfolio back then, and I have a chapter in this book on quality improvement. Bob Greenis' book on clinical decision support is a classic and a mainstay of clinical informatics classes. And of course, Ted Shortliff and Vimla Patel have been writing books on clinical informatics for decades, the most recent one on the role of artificial intelligence. Next slide, please. Here's another particular example of how AHRQ-funded CDS research has made an impact. So many of you may know about the CPOE, the Computerized Provider Order Entry Tool from Leapfrog, sometimes better known as Leapfrog's CPOE Flight Simulator. You may not know that the initial work was actually funded by AHRQ in conjunction with the California Healthcare Foundation, RWJF, and then enhanced with further our funding. This is work led by Dave Klassen and David Bates. This test takes a healthcare system's EHR through a set of simulations that essentially stress tests it to make sure that it has key CDS functions that ensure patient safety. And it's really important because, as you all well know, and there was a comment in the brief discussion earlier, what a healthcare system buys off the shelf, as it were, and how that system is actually implemented and used can be two very different things, even among sites within the healthcare system that has purchased and implemented the same EHR platform. Over 2,300 hospitals have taken this evaluation, and as David and others have published, it has that impact. So there is a 43% relative reduction in adverse drug events predicted for every 5% increase in Leapfrog score. So the higher your Leapfrog score, indeed, the lower your predicted rate of adverse drug events. Next slide, please. It's also worth highlighting 2 particular early decision support demonstrations that our program has funded, and those that really laid the groundwork for later and even ongoing investment today. And one was called the Clinical Decision Support Consortium, or CDSC, led by Blackford Middleton at Partners Healthcare at the time. The other was the GLIDES project, Guidelines into Decision Support, led by Rick Schiffman at Yale. This was in the 2008 to 2012 timeframe. And speaking of training and impact, I actually have a personal connection to these projects and look back them quite fondly. I was a practicing pediatrician for many years in Connecticut before deciding to go back into training and do my informatics fellowship. But when I did, I went back to Yale and joined the GLIDES project. And the first paper that I presented as part of GLIDES was a paper on deontic terms, those words of obligation like should, may, must, that often appear in clinical practice guidelines, but are really hard to transform into decision support. That was based on a survey of attendees of the 2008 AHRQ annual conference. So some of you who may remember those or attended those may have received a link in the survey invitation from me. A convenient sample for sure, but I like to think that you, AHRQ, and supporters of AHRQ have invested in me those many years ago, and now hopefully I'm giving back a little. The job that I took after the fellowship and working on GLIDES was here at AHRQ, and I've been here nearly 14 years. Next slide. So what those 2 contracts really did was identify how we might get to clinical decision support and knowledge management at scale, things that are still relevant today. And I won't go through all the details of the graphics or the papers, but a few points. So for the GLIDES project, we learned about the importance of tooling and standards and of incorporating informatics into guideline development and implementation. Recall the roadmap paper I mentioned earlier. We need standardized tools to help us increase the efficiency and reduce the unnecessary variation that comes from translating guidelines into decision support at every healthcare system across the country. It's worth noting that the often cited figure of 25 billion, that's the amount we spend nationally for essentially redundant, duplicative effort, where every healthcare system has to tackle translating guidelines into recommended care through decision support in their own systems, a process that's essentially repeated in siloed fashion from one healthcare system to the next across the country. That figure, 25 billion, comes from a study originally conducted by the CDS Consortium. They tackled what it would take to develop governance and best practices across healthcare systems using different EHRs. i.e. knowledge management at scale, even recommending a national repository of decision support. And remember this when we talked about CDS Connect. But no surprise, these challenges were difficult. Those demonstrations were conducted 15 years ago, when many healthcare systems were still using homegrown EHRs and well before FHIR and USCDI. Next slide. Which brings us to our next wave of investment in decision support funded by the P Corps Trust Fund. And I know, as we've heard, the NAC and the P Corp SNAC have heard a lot about our P Corp TF investments, but perhaps less so about the specific mandates in the ACA for what AHRQ should be doing around clinical decision support. And I find the actual legislative language very interesting. It's not common for decision support to be specifically articulated in the way it was in the legislation. And as far as I'm aware, it's the only instance of legislative language that ties CDS to AHRQ specifically by name. But in a nutshell, the legislation requires AHRQ to, as part of its dissemination and implementation category, as Karen mentioned earlier, 1, work to use decision support to advance P Corps evidence into practice, and 2, to work with specific stakeholders, including patients, vendors, professional associations, clinicians, and others to get feedback so that we can achieve our mandate in the best ways possible. Next slide, please. We have essentially used what you see here as a way of organizing our P Corps TF mandated activities. Our overarching goals have been to advance evidence into practice through CDS, as I mentioned, but also to make CDS more shareable, standards-based, publicly available. And these activities have generally fallen into one or more work streams, namely 1, stakeholder engagement, 2, infrastructure for sharing and developing decision support more efficiently, 3, continuing to learn more about how best to accomplish our goals through grant-funded demonstration and dissemination research. This gets to the scale question we noted earlier, and evaluation. Before I dive into the infrastructure stream, which is really where I'm going to take the presentation next, I want to highlight one recent aspect of our patient engagement work, which actually relates to some of the comments in the early discussion. So if we go to the next slide. That is the notion of patient-centered decision support. And again, not going to dive a whole lot into this now, but I do think it's worth mentioning. One of our current funded contracts that is with NORC is the CDS Innovation Collaborative, or CDS IC, led by Jim Swiger here at AHRQ. And the CDS Innovation Collaborative is advancing this concept of patient-centered decision support by bringing in patient, family, caregiver perspective into the way we design, implement, and evaluate CDS. And not just for patient-facing applications, but for many applications. We have patient voices in almost everything we do in the project, from its steering committee to its many work groups, so that we can learn what is the best way to co-design decision support all types of CDS in a meaningful way that helps CDS address what matters most to people. And as a quick side note, I'll just acknowledge and give a shout out to Mr. Millenton, who you might remember we met a couple of years ago, and you lent some great insight actually into how we might explore this area. And I'm happy to catch up with you and anyone else who may be interested in this topic, which I think AHRQ is actually leading in terms of what it means for patients and caregivers to be more engaged throughout the CDS lifecycle. And as a program, we're thinking about how to measure that value. Next slide. So I mentioned infrastructure, and the premier example of what we've invested in and tried to demonstrate is called CDS Connect. And this is led by Mario Turan on our team and our contractor, MITRE, who has built CDS Connect with us and maintains it. We presented to the NAC before on CDS Connect, and actually one of those presentations had to do with getting input from the NAC on what to do with CDS Connect longer term. And actually you, Dr. Robinson, you were already part of the NAC at that time and made me remember that presentation. That was the topic back then, and sustainability actually is a primary topic for today. But before I go there, I wanted to give a brief recap for those who may be less familiar with this and what it is and where we are with it today. So CDS Connect is actually many things at once. It is a website for sure, a web address that you can plug into your browser to discover information about decision support and shareable CDS resources. It is a platform to help facilitate that sharing. So it has a repository that you can search and download from, download resources or artifacts, as we call them, such as flow diagrams, value sets, logic statements in the form of clinical quality language and many other types of things. It is a set of tools, including an authoring tool that helps non-software engineers write clinical quality language. You might know that CQL is an HL7 standard that specifies logic for both decision support and electronic clinical quality measures. And this is one of those important connections between what we're doing on the CDS side and what CMS is doing on the quality measurement side, in that we're trying to use the same health IT standards across decision support and measurement, so they're consistent and can be leveraged for each other. And ultimately, CDS Connect really is a community of developers and contributors, all with the goal of making it more efficient to develop decision support and to learn from each other in the process. Next slide. In terms of where CDS Connect stands now, here's some recent stats. The repository has 77 entries. Note that's not the number of actual resources, because many entries contain many resources corresponding to a particular use case or demonstration. Many of our funded grants, both cooperative agreements and dissemination grants, contribute to CDS Connect. We have over 1,000 globally registered accounts. And interestingly, something we didn't anticipate at the beginning, a fair number of users leverage the authoring tool to teach decision support. Hopkins, for example, uses it in some of their informatics classes. Next slide. So I mentioned sustainability in our presentation to the NAC some time ago, asking whether we should pursue exploring what a public-private partnership or collaboration might look like for CDS Connect in the future. And the NAC at the time was overwhelmingly in favor of us exploring that further. It took a little bit of time, but this year we launched phase 1 of that formal exploration, which really focuses on gaining public input. And we've done that, or are about to do that, in 2 important ways. One is a challenge competition, and the other is through a formal request for information. So next slide. The challenge competition was recently launched and completed, though the winners have not yet been announced. The challenge really focused on the design of CDS Connect and what people think such a platform, again, for sharing and reusing interoperable decision support so that healthcare systems and developers don't have to start from scratch and they can actually learn from each other. What does that future vision and version of CDS Connect look like from the standpoint of functionality? We also asked submitters to tell us where and how the value proposition might become clear for both contributors and users, given decision support is expensive to develop, deploy, and maintain over time. We asked them to articulate and describe through their design who should be involved, what the roles and authorities would be. And we asked submitters to think about business models. The competition was conducted in 2 phases. Next slide, please. The first phase was a written submission, and the second phase is an oral presentation. And we've announced the first phase winners that you see here, but have not yet announced overall winners based on both phases. But the prizes have different categories around overall design, technical functionalities, value proposition, and innovation. And winners in each category can receive $25,000 in prize money. Next slide. So here are the key takeaways from what we saw submitted. And I think it's worth slowing down a little bit and talking about this, because it helps us to set up some of the questions we'd like to ask you in a few moments. So first, the submitters identified some clear wants from CDS Connect, or a future version of it. One, functionality that harnesses the power of AI. Probably not a surprise, but how and what that looks like is something we need input on for sure. 2 is seamless integration with EHRs, more plug and play. Again, it's very hard and resource intensive to do implementation well, depending on the state of the starting material that you have. That is the CDS artifacts that you have at your disposal to start building your decision support. Educational resources, they recognize that people want and need help understanding what shareable CDS is, what it may or may not do for them, how to use standards, and so forth. An enhanced user experience. In terms of CDS Connect's role in the CDS ecosystem, submitters envisioned CDS Connect as an authoritative source of trustworthy CDS and a go-to hub for reusable, interoperable building blocks of CDS, just like I've been talking about and just like we originally imagined it. But they also pretty strongly reiterated the importance of AHRQ continuing as a trustworthy partner, and AHRQ's role in governance of the CDS Connect of the future, and continued support for CDS Connect to live on in some form of public-private partnership or collaboration. Next slide, please. Before we pause for discussion, I just wanted to do a quick update on next steps. I did mention a formal RFI, which we hope to release over the summer. And in particular, we'll be looking for perspectives from industry, similar to the design challenge that we'll want to hear from a broad audience around functionalities, roles, potential impact, and potential partnerships. We will complete the design challenge evaluations and announce winners as mentioned. And really the end of this phase 1 exploration culminates with an analysis and a recommendation for AHRQ and our AHRQ director. Okay, so next slide. These were the questions that we would love to hear your input on. I'm happy to read these, Armando, or if folks have already seen them, you can just dive into the discussion, whatever you like.
So these things that, well, one thing for your presentation and your work over the years, I happen to remember some of those discussions that we were having through that time, including some of them that were remote because we were going through COVID. So some of that stuff was, so I definitely remember that, and really nice progress that you all have made here. For these questions, I believe it was group, I want to say it was group 4 that actually is familiar with these questions. The other 3 groups may not be familiar with these questions, but so I'll be really leaning on group 4 to jump in on these. But I did promise Peter that I would have him jump in first during this time of conversation and discussion and questions. So Peter, go for it.
Yeah, thanks so much. Actually, it was good that I waited because a lot of my comment was going to be covered. My original intent of putting my hand up was in reaction to one of your suggestions in our pre-conference group, and that was how do we engage NAA within the under-resourced areas, and the technology came up very quickly. And then as a part of that conversation, some of those suggestions were brought out in the last couple of slides. And it was more, how do we facilitate the development of a learning collaborative, primarily through that public-private type of interface? Because, you know, there's large tech companies are now getting more visible in healthcare, and therefore they obviously have larger pockets in many ways. So it was to really encourage more activity in those under-resourced areas as opposed to pilot projects in the well-resourced areas of the industry overall. As I saw the history there, it was great to see. I recognize a lot of the names. Our organization's worked with several of those. We've collaborated with Chime, Amy, et cetera, et cetera. So what you guys are up to is terrific, but let's, you know, figure out how to do it in the different verticals within our industry so that everybody benefits. So thank you.
No, that's a great call out. And one of the things just to add, especially on the public-private partnership side, we've got Dr. Hunt here. I keep calling him Dr. Hunt because we have 2 Davids. So if I say David, it's not sure which one I'm referring to. Is, you know, I think one of the, and I'm calling out ONC specifically, is because I think a really nice model for public-private partnership is CancerX, and really thinking about how to deeply engage a broad market of technology, you know, kind of producers, users, there's patient advocates, and so forth. Really bringing them together and focusing in on that, and that vertical that's obviously focused on oncology on the White House's Cancer Moonshot goal. But imagine that you can direct a similar focus to the topics that you've described here, Ed. It could be really, really interesting. So that, so there's a model, is my point, out there of how you might do this in a deeply effective way.
Yeah, you know, thank you for both comments. You know, just to quickly go back to Peter's, I wholeheartedly agree. And in fact, one of the main motivations for starting CDS Connect, and honestly, most of what you've done, is to try to help those settings, environments, institutions who don't necessarily have all the resources as other folks, perhaps. On the one hand, one could, if one were simply wanting to affect the greatest numbers of people, one strategy could have been to target those developers and vendors or platforms that reach the most number of patients, right? On the other hand, a lot of places do not have the capacities, informatics capacities, implementer capacities to really do that, or have purchased those systems, right? And in fact, for example, in the CDS Connect project, 2 of the first 3 demonstrations we did were with health center control networks, right? Trying to help use the HCCNs to get to the reach of underserved communities. And one of the things we found was the interest for sure is there, but the last mile problem, the ability and need for continued support of applications, decision support is hard for folks from the contributor side and also from the implementer side. And so your thoughts and next thoughts on how to do the full spectrum of support, not just developing something, putting it out there for folks to hopefully reuse. How do we actually make it so that that scale gets there and also continues?
Yeah, those are tough questions, but those are the right questions. And Dr. Hunt, I did see you come off of mute for a sec, so I wanted to give you a chance to pipe in here as well.
No, I just wanted to say that ONC in general, and I personally have been working closely with Chris and definitely with Ed on a lot of their projects, and there's very, very tight coordination from our office on their work.
Okay, that's great to hear. Jaji, you were next up.
Okay, so number one, Ed, thank you for the great summary and the history and everything. Actually, I personally know most of the PIs on your slides. And in old days, I used to use art and syntax to run among rules. Okay, that's old days. And a specific comment for the CDS Connect. There are 77 artifacts over there. I went through some of them. They are beautiful, very organized, and good logic. So now the question is how to get this into the workflow in the right context to do the things. I think you're all aware, but for me personally, I strongly believe the recent breakthrough in foundation models, large language model in combination with all the logics together can fundamentally change all the CDS type of tools. I mean, we know the old ones, I mean, the ones that are there, and some work really well and only in specific context, and most of them do not really work well. And many of them are not used in the practice. Okay, so what is the thinking or potential long-term strategy for AHRQ to get involved in combining the traditional CDLs, artifact logic and everything with the new wave of products which are real?
Great question. I am not sure I have a good answer. I think I would also toss that back to you and to the NAC a little bit, and to Chris if you have ideas. The combination of decision support with AI, large language models, general AI is a new frontier. And as we heard, two things I guess I'll reiterate from we heard from the submitters of the challenge. One is, as you said, getting into workflow, more plug and play, right? So the idea of putting some starting material out there is great, but it's not enough. And the other is how do you make that easier? And there are methods perhaps for doing that easier. It could be through AI, it could be through any other methods. And so if you have thoughts about how to do that, how to fund research around it, how to do it quickly, given the field is moving that quickly, you see me looking this way, it's only because I'm taking lots of notes.
We know how to do it, or we simply need the grants.
That's definitely one mechanism to leverage for sure. And I'll call out, so earlier today in conversation there was this idea of, hey, do we hold the EHR vendors accountable in some way around this, and not simply kind of leave it all on the shoulders of the providers and others, but actually hold those folks in some way accountable, which is a great concept, how to do that, how to operationalize that, to be determined. But it reminds me, and I think this came out relatively recently, a Forbes article around how, I won't call out any specific EHR vendor, but you guys all know who they are. It does a really good job of making innovation really hard for anyone outside of that entity itself, right? And so the actual ecosystem to innovate in this space is not it's not fertile ground, and part of that is on the technology vendors. A good chunk of it, honestly, is on the technology vendor side, and so now we have to start thinking. As much as you don't want to necessarily use policy levers to push on private companies, maybe you have to think about what are the policy levers here to move these forward. And maybe that part is part of the recommendations that we'll leave with the director and the team here at AHRQ. So just something to keep in mind. And if anyone needs a link to that article, I can send it to you offline. Liz, you're up next.
Thank you. I just have I want to thank Christine and Ed, and the question really is for Ed. Ed, you'll have to forgive me. I am not an expert in the digital space. I am fortunate to have learned electronic health systems at MGB or Mass General, so I know Octo and Blackford and David. And, you know, from the user perspective and a quality and safety perspective, I know some of that has been built by folks at the system where I work. So now you have this wonderful thing, the CDS Connect, and you want to get it implemented. So this is my question, and it may be very basic, so forgive me, but imagine you're responsible for clinical decision support in a system that doesn't have all these internal resources. What are your options? I mean, I guess at a minimum, you just rely on what comes with your EHR, presumably you have an EHR at this point, or you bring in a consultant, or you hire the right people, or you use CDS Connect. I mean, what are the options and what are people doing? And how could we make the CDS Connect resource easier to use, less friction, so that you have more uptake? But I'd like to know a little bit more about what really goes on in systems today. What's the range of quality in CDS, and what do the leaders have as resources or options for improving the quality of CDS?
So thank you very much for that question. It is not a basic question. In fact, I think it's the question. It is, I think, to get your second part first, the choice for systems who are not the Mass Generals, not the Brighams, not the pick your academic medical center of choice, unfortunately, I think is rather limited. Either you kind of take, as you said, what comes with your platform, EHR platform, or any other platform that may be in use. You try to purchase what you can, or you try to develop in-house what you can, which may not be a lot. And in fact, that gets right to the question we talked earlier, but how do you scale to other places that just don't have that capacity? That was actually one of the main motivations. But it takes people and resources and over time, for sure. So one can make it more plug and play so that the maintenance and effort to plug it in and have it play well over time is less. But there's no easy answer, in part because the motivation, for example, I'll just give one more kind of concrete example. Even well-resourced institutions who wanted to contribute to CDS Connect for sheer sharing purposes, so that they know that this sort of disparity exists, it is hard for them to host something, let's say, and continue with the support that another institution is going to need for that. Because it's not something that is naturally sort of built into their models around continued support. Now, we should love your input on how we can sort of solve that, or some other ways to sort of deal with that. But it is the question. I think it's a good one.
Any other questions or thoughts? And I'll call, I see you, Sunil, I'll call out group 4 as well here as the lead for this part of this section of this conversation. Sunil, go ahead.
Thanks, Edmondo. And just following on the comments that have been made, I wonder, are there two things? Are there opportunities within CDS Connect for not just the developer of the clinical decision support, but another site that has subsequently implemented it to also share their lessons learned and maybe some additional steps they had to take to utilize those artifacts which currently exist in a way that could benefit further downstream users. So that's one comment within CDS Connect. The other gets back to the public-private partnerships. I wonder, as AHRQ is so invested in this space, is there an opportunity to work with the vendors to somehow facilitate the sharing, at least within their client pool, of some with some greater facility around CDS tools that have been developed? Unfortunately, I mean, my own experience with this is that the local installations of big products are so customized in cases that they can't just automatically be ported over to another installation of that same platform. But there has to be some step back that could be taken so that CDS tools could be more readily mapped to other sites that are using that same vendor product. And I don't know if standards for that exist. Supporting the development of those types of standards might be a role that AHRQ and its partners could play in this space.
Great questions. So the first one around opportunities for developers and sharing lessons learned. Absolutely, that again, one of the main motivations for CDS Connect as a community. In fact, several of our demonstrations created, I think there was a comment earlier about implementation guides, and I mean small I, small g, not like in the HL7 context of formal IG. But a lot of those implementation guides that we put forth that have encouraged others to develop also have decision logs. What the special sauce is the kinds of things that why you took the left instead of a right, why you chose this value set versus that value set. The things that need tailoring and really, not necessarily customization, but you need to know why that is appropriate for your setting or not. That really should come through in a community of learning like this. Absolutely, I agreed. The other part about public-private partnerships and working with vendors, we have actually worked with vendors quite well, I think, in terms of our relationships. We have vendor representatives across our program. And a few success stories in the sense of AHRQ-funded research actually scaling across a major vendor and their app environment, so that is available to others. And happy to share the details of that. Some of that actually has already been published. And so try to do better around that. And if you have ideas about how to do that and make it easier, and as you said, trying to figure that out.
Thanks, Ed. Al.
Thank you, Armando. And so we were group 4, and we had a lot of discussion around this. And I want to start with the last topic that's really been discussed about how do we get this information out more. And one of the things that our group talked about, well, first, that technology is the answer, and that, entry point is getting lower and lower and more accessible to, as we talk about catching diagnosis as early and having providers better and more areas of access, such as in rural areas. One of the things that was mentioned was that when grants are awarded, and these grants are usually going to some of the usual actors. So you talk about Mayo, you talk about Johns Hopkins, and some of these larger institutions. And so one of the things that was mentioned in the recommendation is maybe we should look at taking these grantees and making sure that those that are awarded a grant or what have you have to pair with some other underserved system or another institution that is traditionally unrepresented or underrepresented in the area where it can be implemented with the same usual cases. So, as we talk about how do we expand this out to some of those other institutions, maybe we look at a pairing of sorts to be able to do so. Have the grantees demonstrate solutions that will work well with different populations and provide some of these tools to be able to do so, making sure to keep that technology the same, but practical, that it can work in many different ways with many different clinics, with diverse organizations, with different clinical matrix to make sure that it works in every just as well. And then AI can be used in underpopulated and underserved areas, specifically for curation purposes. So one of the examples that was brought up in our group was you have a surgeon who is in a rural area and he's having to do a surgery that he hasn't done since his residency. And so to accept those risks, maybe have the development of some type of confidence intervals using AI, or which increases that confidence as well. But then also making sure that the patient, we talk about that patient-centered model, that the patient confidence is there as well. And so having that transparency, educating the practitioners on that patient communication and utilizing those services and skills. Going back to the beginning of the question, and we kind of talked about this a little bit about how everything is AI focused, and we know that that's going to be focused moving forward. And it's a really hot topic, but with CDS Connect, the logic right now is extremely hard to use and not practical to use at this time. And so how do we get the logic involved and integrated to make sure that it is implemented? And I mentioned earlier, as it was part of the discussion with our group, of some type of defined implementation guide, and that this is necessary in the way of a module or some type of algorithm. And then making sure that that clinical decision support is multifactorial and doesn't interface with the complexity of the patient and and right now is a struggle. And so that lack of connectivity is challenging. However, the technology and that potential is there, but making sure that it's not that the support, the clinical support integration is not simple, that it can be used in that multi-factor way. And currently it doesn't do that. And in addition to that, it was, how do we support other factors such as harm, et cetera? The pathway forward needs to make sure that it has relevancy and predictable based on the complexity of the patient. Having CDS used in institutions to give them predictive models will be of most use. And then rule-based approaches should be applied along the different stages and be more prospective instead of retrospective. That's one of the things that was highlighted, is that everything we do is after the fact and not prospective in comparison. So taking that different approach as it pertains to looking at this. And then lastly, and we kind of answered question 2 in question 3, seeing that question 3 was the same answer as question 2, is how can the metrics be tied into the CMS quality program metrics? And I think there'll be added benefit towards the integration if you have some type of tie into those metrics as well. And I don't know if anyone else from Group 4 wants to chime in on anything that I missed.
Anyone else before Ed responds? Anyone else from Group 4 that want to add to Al's summary? I just want to, so I think it was a great summary. From what I heard when I was popping in and out, I just want to kind of re-emphasize that aspect of like end user usability, right? So great, great on the surface, but at the end of the day, when you've got to actually, get this thing in and get it used, I think that's where some of the drop off is. And so, what is that, and how do you address that?
Thanks for the comments. And I think most of those comments are for us to sort of internalize and think about it. We definitely will, and I hopefully I got all that right. Just a couple quick comments. One is around the barriers to entry and trying to serve, again, those places that may not necessarily typically be the primary on an AHRQ grant. One of the things I think we've had good success with that we continue to focus on is our R18 mechanisms. So folks may not know that SBS familiar with the activity codes, but R18s are really demonstration grants, where the idea is you have an existing evidence, and the whole point of the research is to demonstrate scale. And one could, as you said, be more deliberate around seeing or how you could require, or how you could be more deliberate around where that scaling happens, to which sites, right? And so I think that is an awesome suggestion that we've thought of, and we'll continue to think about how to actually reach those places that may not be the primary grantee. Around the CDS Connect logic, I agree with you, it's hard. I think there are definitely pros and cons, and sort of meshing a traditional, I guess one might say, CDS with AI. One of the pros of the hard logic is that it's very transparent. It's hard to engineer. It's hard for some. It's for me. It's hard to write, but it's very clear what goes in, what goes out, or what's supposed to come out. And so thinking about how to mesh that with more AI-related methods, I think would be great to get your input on, and how to foster that research. And definitely we would love to have more integration with the CMS quality measurement program and that side. Thank you.
Yeah, those are great points. We've got a little bit more time for discussion here. Sherry, I saw you pop in, and Sherry said we did intros, but you were in your other meeting. So can you just do a quick intro for the new folks,
Sure.
then go your question, comment?
Yeah, just checking. Can you hear me? Can you hear me?
Yes.
Okay.
Mhm.
Sherry Ling, Deputy Chief Medical Officer, Centers for Medicare and Medicaid Services. And just wanted to build on Edwin's comment about the intent of aligning with the opportunities through CMS programs and quality measurement and all that. Need to also emphasize some of the points that were made about how usability testing, if you will, of any concepts that are intended for purposes of quality measurement, that the measures have to be usable as much as they are useful. And so we really want to focus the technical opportunities on that which will be meaningful for the people who we serve, sometimes called patients, and also the clinicians and health systems. So all these factors, the opportunities, I think, exist. We go through our usual processes, but we want to be really true to what Ed was speaking of as far as the testing and all of that, which I've just mentioned. So thank you so much for asking the question, though. Appreciate it. Over.
Thank you, Sherry. That's perfect and great way to wrap this section of this part of the presentation. Chris, I think I'm going to hand it back to you. What we're going to do is you'll have 10 minutes from a presentation perspective, and then we'll have 10 minutes for discussion afterwards. That's how we'll wrap up this agenda item.
Sounds great. Thank you. If we could have our slide up, please. So my team is also really excited to share with you our recently released evidence and consensus-based digital healthcare equity framework and the accompanying practical implementation guide, which were supported by Johns Hopkins University and NCQA as our partners. Next slide, please. So as you all know, digital healthcare technologies provide considerable opportunities and potential to improve healthcare delivery and outcomes. But the positive impact of digital technologies at an individual and population health level are going to be limited if the unique characteristics, needs, and capabilities of all affected groups are not considered by designers and implementers of these technologies. As a result, these technologies and solutions can create new or exacerbate existing healthcare disparities for those trying to access and utilize healthcare services. The Ziad Obermeyer article, which is pictured on the right, just a few years ago identified racial bias in a widely used algorithm to manage the health of populations. The bias arose because the algorithm used healthcare costs as a proxy for healthcare needs. But unequal access to care means that we spend less money caring for Black patients than for white patients. So healthcare need was not accurately predicted for Black patients in the case of the use of this algorithm. Another, yet far more simplistic example, and one we highlight in the guide, is when the COVID-19 vaccinations were first approved and ready for rollout. Initial intent was to register the most vulnerable for a vaccination appointment. Across the country, health systems and pharmacies rolled out digital signups, which unfortunately and unintentionally undercut the goal to reach many of the most vulnerable because the designers and implementers didn't think about the characteristics of the affected population. I still remember stories about grandparents calling on their grandchildren to help them sign up for a vaccination appointment. Our framework and guide can help an organization think through these proposed solutions and interventions more intentionally before they affect patient populations. Next slide. At the time when we embarked on this project, there was little guidance for how organizations should and can intentionally consider equity across the digital healthcare lifecycle, which is depicted to the right of this slide. So we sought to fill that gap by working on the goals noted on this slide. Next slide. To develop the framework, AHRQ contracted with Johns Hopkins University and NCQA to conduct an environmental scan of all the health equity frameworks and digital healthcare frameworks in the literature at the time. The scan included key informant interviews to provide additional background information and insights to augment our search. We also organized a diverse, really high caliber technical expert panel, or TEP, composed of 30 experts from industry, academia, health systems, providers, to provide insights into the shaping and eventual consensus around the framework across a series of meetings, discussions, and surveys. The TEP was equally important in the structure and usability testing of the guide, bolstered by real-world examples. Next slide, please. I know this is a pretty dizzying graphic, but it highlights how identifying, mapping, and harmonizing the plethora of models and frameworks identified by our environmental scan, coupled with the key informant interviews, led to the identification of an initial set of domains and concepts, which are noted on the mid-left of this slide. And working with the TEP, JHU, and NCQA, we consolidated that initial set of domains into the domains and subdomains depicted on the right-hand side of this graphic. Those became the elements of our digital healthcare equity framework, which is depicted on the next slide, please. So what emerged here is an evidence and consensus-based framework guiding key stakeholders to intentionally consider equity in healthcare solutions that involve digital technologies. The framework identifies key stakeholders that need to be involved, the key subdomains that need to be considered at a patient and community and health system level, as well as the key characteristics of the information technologies that need to be looked at across the digital healthcare lifecycle. The ultimate goal of utilizing the framework is to have a positive impact on health outcomes. But we didn't want the framework to be just a mere academic exercise. We wanted to develop something that's practical and useful to help key users involved in the planning, development, acquisition, implementation, and monitoring of healthcare solutions involving digital technologies. Next slide, please. The guide was iteratively developed based on recommendations from the project's TEP and key informants, so it could be useful regardless of the organization's type, size, and solution complexity. The primary users of the guide include digital healthcare developers and vendors, health systems, health plans, and clinical providers. Next slide, please. If you could hit enter, please. The guide is divided into 3 sections comprised of specific phases of the digital healthcare lifecycle and its corresponding user groups. This first section is focused on the planning and development phases. Primary users are digital healthcare developers and vendors, but we note that some health systems, plans, and providers also plan and develop technology solutions in-house, and therefore steps under this section are applicable to them too. Please hit enter again. The second section is focused on the acquisition, implementation, and maintenance phases of the digital healthcare lifecycle, and is for health systems, health plans, and clinical providers. Please hit enter. Thank you. The third section is focused on the last phases of the digital healthcare lifecycle, the monitoring, improvement, and equity assessment phases, and includes a checklist of steps for health systems, health plans, and clinical providers. Across all of these checklists, users can click on a step to be directed to real-world examples that further illustrate aspects associated with a particular step, as well as the characteristics of the domains and subdomains involved in that step. Next slide, please. We're planning a fairly strong dissemination strategy to try and get the guide in front of the intended users. We'll do a soft launch later this month, but the environmental scan, framework, and guide are now available on our website. I believe the NAC was sent a link that would take them to the web page that contains these documents. We'll do an official launch in April with a blog during Minority Health Awareness Month. We have submitted 3 abstracts that we're hopeful will be accepted at national meetings noted on this slide. We're also considering a journal manuscript as well as a webinar focused on the framework and guide. Next slide. So we mentioned a bit about our history and what DHR has accomplished over the past 20 years. And we'll close now by sharing a few thoughts about next steps for celebrating our 20th. Next slide, please. We've been developing a campaign to celebrate our 20th, but we also hope our campaign will serve as a catalyst for greater awareness of the terrific research we support and its potential for transformation as reflected in our new tagline, advancing today's discoveries, transforming tomorrow's care. Next slide. Last year, my team developed a strategic communications plan per recommendations from key stakeholders. We identified 4 key goals, which are depicted on this slide, along with tactics to realize those goals. The 4th goal is doing something we haven't always done a good job at, which is celebrating the great work and people that have contributed to the field whose research we've supported. It helps that our 20th anniversary was just around the corner when we developed this plan and served as a catalyst to implement many of the tactics within our strategic communications plan. Next slide, please. On this slide, we've noted some of the tactics we're employing. I hope you saw the recent AHRQ blog officially proclaiming our 20th. This is the first of 4 that will focus on key areas that AHRQ has been at the forefront of and where we think things are headed. We're also currently engaged with the American Medical Informatics Association, or AMIA, to identify opportunities to promote and showcase our 20th. Last year alone, between AHRQ staff and DHR grantees, we accounted for over 40 sessions at AMIA's annual symposium. And Dr. Robinson, I know you had one of those sessions too. One of the exciting panels we have on tap, Ed foreshadowed a bit, is having DHR grantees, Jim Cimino, Patty Brennan, David Bates, and Sue Bakken, who were awarded with informatics' highest honor, the Morris Cullen Award. Morris Cullen was mentioned earlier in our earlier history presentation. And they're going to be discussing 20 years of innovation and what the future might hold. We also have an AMIA perspectives piece in the works reflecting on these past 20 years. Next slide. And now we'd really love to hear from you.
Thanks, Chris. That's a great summary, and both on the equity side, which had been called out earlier. So I'm glad you were able to pull that together, as well as the 20th anniversary piece, which is just one great celebration and an opportunity to do more. At this time, in terms of I'll take questions, comments, and also I'll call specifically out. This is group 3, and the spokesperson for that group in terms of some of the discussion that they had in the pre-session this morning relevant to this topic. Don't remember who that person, who they picked for group 3s. Let me see if I can. Who they picked? Sunil, do you know? Is Sunil on? Sunil, do you know who they picked?
Yeah, Michael. Michael took notes.
Oh, okay.
Oh,
that's right. That's right. He was the
Sunil, I'm happy to defer to you since you are our coordinator. Why don't you take us through it?
Okay, happy to do that. Let me just get your notes in front of me here. All right, so we had a great discussion about equity in this very broad digital space. And I think from the outset, it's important to emphasize that the digital health portfolio spans everything from individual user apps all the way through to AI and large language models. And with that comes a lot of opportunity, but also a great deal of challenge, just wrapping your arms around all that as an organization. One of the key issues that surfaced early in our discussion, especially around individual patient access to technological platforms, hinges on high-speed internet availability. In our rural communities especially, and one of our members pointed out that that's just often not the case, that high-speed internet's available, still using DSL, for example, as sort of the medium pace platform. And is there an opportunity to partner with telecommunication companies that need to map their areas of coverage? And there's a recognition that sometimes those coverage maps may not actually be very accurate. There could be opportunities to provide in certain settings smartphones or iPads, as is done in schools, that could be preloaded with help apps as a way of promoting access to technological innovations that could be very useful for individuals to engage in health and wellness. We also talked about a few research opportunities in this space. As healthcare continues to evolve into more of a team-based model, multiple members of our group pointed out that there's going to be a greater need to study how patients and their family members communicate not only with their physician or advanced practice provider, but also with other critical members of the healthcare team, which may include not just nurses in the clinics, but also social workers and community health workers. And that seems to be a gap in a lot of the research in this space. And another gap that our group pointed out is, in spite of the proliferation of numerous consumer-facing apps for healthcare wellness and self-management, there's not a good evidence base that those types of apps or particular apps are actually effective in improving either individuals' navigation of their care or their health outcomes. And so that's going to be a critical area of work going forward. One concern that was brought up is around safety. As an extension of the email phishing conversation earlier, data security is going to be critical, and not only for protecting patients' information, but also making sure that everyone has confidence as these tools proliferate. There are other industries outside of healthcare that have done a wonderful job maintaining data security. The banking industry was brought up, for example, and there could be greater opportunities for our healthcare institutions and government organizations to learn from approaches that other industries have taken to maintaining data security. All this requires partnerships, which was another area we spent some time talking about. Partnering not only with those security experts, but also keeping an eye on the growing shift in the healthcare arena as hospitals consolidate, as individual companies that might have started, for example, as a drugstore company, grow their portfolio of business to include claims processing, to include care delivery directly to patients. Engaging with those growing entities in this shifting healthcare landscape is going to be very, very important as part of AHRQ's broader engagement, but also specifically in technology. And there are a number of other groups that were felt to be important partners. One is the National Association of Medicaid Directors, America's Health Insurance Plans, the Alliance of Community Health Plans, newer groups like the Long COVID Alliance, which includes patients as well as researchers and healthcare professionals, Patients for Patient Safety, Society for Participatory Medicine, and a couple of other groups. Michael, who by background is a professional writer, also pointed out opportunity to engage with the National Community of Science writers to elevate some of these topics and reach broader audiences that we may not normally reach as we focus on more academic outlets that researchers and healthcare professionals tend to seek. In terms of specifically promoting use of the Equity Framework Guide, tapping back into those partnerships to reach communities which we wouldn't necessarily reach through our traditional healthcare channels could be very important. And, a couple of areas, in the public-private partnership sector might also provide opportunity to disseminate the Equity Framework Guide. Academic medical centers, for example, are rapidly accelerating equity programs and attention to equity and use of an equity lens, but are smaller technology developers doing that? I don't know personally. If there's a way to reach those developers to highlight the importance of incorporating equity into new tools that are developed by these smaller startups that may still be reaching a lot of patients, that could be a very important way of communicating the importance of having equity as central to how we look at rollout of new digital technologies.
That's a great summary, Sunil. It sounds like a rich discussion that the group had. Thanks for summarizing for us. Anyone else from the group want to add any pieces and fill in any parts that you wanted to highlight here from that group?
Yes, thank you. I was furiously
Go ahead,
taking
Chris.
notes.
Yeah, go ahead.
I was furiously taking notes. Thank you very much for those comments.
Awesome. Great. So got feedback. Any other comments outside of group 3 that want to jump in here to add to this part of the conversation? All right. Seeing none, and we are out of time on this topic, but we're back on time on our overall agenda. So thanks all for efficient and effective presentation, questions, and conversation. Thank you to Ed and Chris for walking us through this section of the agenda. What we'll do at this time is we will take exactly a 10-minute break. Maybe it's 10.5 minutes. It's still 1:49 on my clock. We will be back sharp at 2 p.m. Eastern time, and we will go to our next agenda topic. I'll take Kamal to come in and with your question, and then we'll have the group, I think it was group 1, who had a summary of the discussion that took place in the pre-session this morning. Kamal, go ahead. You start.
Yeah, thank you, Edmondo. Firstly, congratulations, Craig and the whole team for this just remarkable movement, and sort of seeing all the pieces begin to come together is just truly exciting. So we had a lovely discussion in group 2 about the questions that were posed regarding sort of motivating entities to engage with the National Action Alliance. And the question really started with what might best motivate healthcare systems to engage. And as a group, we really thought that we should reframe that question as to what might best motivate all who are involved in healthcare. And certainly some of the, sort of different examples and buckets that you laid out, highlight the fact that we all have a role to play in advancing patient and workforce safety, specifically, EHR vendors, patient advocacy groups, accrediting bodies, payers, hospital organizations, retail pharmacies were just some of the groups that came up, and it was nice to see some of those listed. A key feature that we thought around sort of engagement was more specificity and rigor, and certainly what you outlined today is a beautiful start, and I'm sure there's a lot more in the works and more details on the website. But what we really wanted to center on was, what does engagement mean, i.e. sort of what is required and what the roadmap for implementation might look like. We also wanted a lot more clarity around how is this synergistic with existing initiatives, and specifically some of the sort of daily necessary transformations that are happening in health systems. We were also very curious how this can bust silos, structures that already exist like sepsis collaborations, state maternal mortality review committees. And we thought that an environmental scan to find those sort of existing organizations and platforms might sort of help promote this work, as those organizations can endorse or promote these efforts. We also were hoping and saw a bit of this on what is the value. Obviously this is a moral imperative, but some examples of value might include how organizations could meet regulatory requirements through engaging in this work, how they might move the needle on current or existing measures. You alluded to some of that. We also thought that, the fact that this emphasizes, rightly so, both patient and workforce safety is something to truly celebrate and highlight over and over again. Someone in the group mentioned and attributed to someone else who I don't remember, workforce safety is a precondition for patient safety. And so, thinking further about how we might engage under-resourced environments, I fully acknowledge that I work at a municipal health system in New York City, and so we'll channel and amplify some of this, but this came up in our group grants to support partnerships with existing grant offices or establish grant infrastructure themselves. Be clear on what's coming off of people's plate. That to me is clear whether you're no matter what kind of resourcing you have. Lower the barrier for best practice sharing and recognition. This might be amplified by partnership with different sort of media or trade kind of publications. Incentives for best practice sharing and sort of shorten that period from innovation to sharing, and create a mechanism to learn from non-success. And sort of highlight that as much as, sort of sharing success. And then, regarding should we target specific healthcare organizations? Again, are there existing organizations like statewide hospital organizations who might endorse or sign on for this? Is there a partnership model where different entities can co-pledge or co-join? An example that was given by one of our NAC members was, well, when someone's discharged from an acute behavioral health setting to, say, a nursing home, would it be possible for organizations to sort of co-pledge together? And is there an opportunity for mentor-mentee type of situations where an organization that might be further along in their journey sort of takes on someone who's an organization who's early in their journey? So thank you for this important work. I do want to see if anyone else in my group, has any comments on what I missed.
Thanks, Kamal. What was your group number again? You were 2, right? Yeah, she was 2. All right. Anybody else in group 2 want to jump in?
I raised my hand. It's Liz.
Oh, okay, hey Liz.
Kamal, as always, did a beautiful job summarizing, and Craig, congratulations on building on Lucy's wonderful presentation in November and presenting an amazing update. I just wanted to put in a plug for what Kamal said about pharmacies. I think med safety is a big concern, and I'd like to bring that group in early on, whatever that group is, pharmacy, pharmacists, because I think look at where cancer is going, for example. So much of it's ambulatory, so much of it's medication, less procedural. So getting in front of that a little bit, and I think that's a lot of where the preventable harm opportunity lies. I guess the only other thing I would say, these organizations like CMS, like the AOs, everybody will want to do this, but if it's completely voluntary, I wonder how successful we'll be given how busy everybody is. So without making it feel heavy-handed, can you talk to us a little bit about the partnerships, in particular with the accreditation organizations and CMS?
Yeah, sure. I just want to thank Kamal and you, Elizabeth, for your comments. There was a lot there. Some of those comments are as you might suspect, addressing activities that are deeply underway. Some of which we can share. Some of which are confidential at the moment. But Elizabeth, to your question directly, I do think engaging healthcare systems, healthcare settings, the healthcare community, as you were saying, Kamal, through member organizations is one strategy that we're working hard to do. So for example, do we reach out to individual hospitals or do we reach out to the American Hospital Association and work with them around what are their member needs and work with them to understand, does this National Action Alliance meet their member needs? And if so, how can we work together to encourage their members to commit? And I think that's the case for a number of different member organizations. It's also the case at some level for regulatory agencies. So these are relationships that are strong, but we're currently doing a lot of this outreach and certainly look forward to reporting back on this outreach in the months to come. I don't know, Jade, if I want to give you an opportunity to to share your thoughts as well on any of these questions, because you're so immersed in this and leading this effort.
Just to add, I couldn't agree more about relationships. And of course, within the federal family, we have extremely strong relationships. And we are exploring as a whole, both with amongst our federal partners, and we hope to with private partners in the future, the different levers that we have, the different platforms that we can use to promote the work of the Action Alliance. So that's really all I wanted to add to that piece of it. I did want to get a little bit finer on whether or not we should, focus in on a particular group. And part of the reason for providing this question is, we are working at a very broad level, but we know that we need to make some quick gains that we can hardwire into the system, right? And give, I think, both patients and the healthcare workforce some early wins that they can hang their hat on, and will hopefully, provide some breathing room given how busy everyone truly is. That is our hope. So one thought is to work directly with in a short, maybe like a collaborative type model, healthcare system leadership as a way to garner some quick wins and learn from high performers and spread those practices through a collaborative type model. And I'm just wondering if you have any thoughts directly related to that thought.
That's for any NAC member, I'm assuming. Yeah, I mean, my initial thought, Jay, would be, there are kind of established collaborations with health system leadership, and so you wonder if there's an opportunity to leverage that as opposed to necessarily spinning something up de novo. That might actually be more efficient, more time efficient, and maybe potentially more effective. And we could probably march through what some of those opportunities are in terms of established kind of convening in collaboration settings.
Edmundo, I'm going to jump in here and just say that AHRQ continues to co-lead the National Steering Committee, and through that group, we have been trying to align, as you saw Craig's nice presentation about how we are actually operationalizing this notion. The steering committee are each organizations that have their own memberships or have their own powers, magic powers, whether it be accreditation or whether it be some other form. So as you may have noticed in the presentation, the Joint Commission was present from the very beginning in discussing these things. So we've certainly tried to align the work that we're doing here with what they're trying to do. And they're actively re-examining their role and their ability to move this agenda forward. The American Hospital Association, which was mentioned a couple of times before, was also on those committees and has clearly heard this message and engaged in their own set of activities within their organization. So the real question is, how do we take advantage of each of our steering committee members' spheres of influence so that we keep everybody aligned towards the goal? And I think that's the hardest thing for Craig and his crew to do, because it's really hurting a lot of different organizations with a lot of different interests, but all who have a similar kind of interest and goal, which is patient and workforce safety.
That's helpful context about things. Before we go to group one, who's going to present their summary, which should be purely additive on top of what Kamal's already summarized. Group one included Kaden, I think Carrie was in that group, maybe Cincy. So whoever is your spokesperson, I want to go to Michael, who's had his hand raised here.
Yeah, thank you. Just by way of background, I've been researching, writing in the literature about patient safety really since the mid-1990s, well before the IOM, and going deep into the literature and then also into the front lines. So let me make a few comments based on that. First of all, this is an extraordinary effort, and I really want to compliment you. There hasn't been anything this comprehensive before. And having said that, I hope you'll take a few criticisms within that context. I'll be happy to talk offline. We have to be careful about the difference between the buzzwords we like to use and what they actually mean. And so, for instance, all the time you'll hear quality is free. Well, that came from CQI for manufacturing people with warranties. In fact, in a hospital setting, if you kill them or cure them the first day, that's the least expensive care. Quality is not free. And you will see, and I've written extensively based on the literature about that medical error can be profitable. And that has been a barrier. And you can see examples in the literature. Similarly, when we talk about workforce, well, I agree completely that workforce safety is important, but it is necessary. It is not sufficient. You cannot have a goal of 50% reduction in both workforce and patient safety. If one went to zero and the other one, nothing happened, it doesn't work. And so, for instance, the IOM report was when there was not people shooting, workforce in the ER and all the other things, and yet they had the 44 to 98,000. So we want the workforce to be safe. It's a Venn diagram, right? In some cases, unsafe workforce, unsafe patients. Some cases, the two are separate. So we have to be careful how we talk about that. And similarly, and I'll go to something more substantial on equity. We mean something by equity, but that's not what the word means. So for instance, I know a white middle-class lawyer who lost all 4 limbs in a nice suburban hospital. If in fact we treat white middle-class people equally unsafely to everybody else who's Black and underprivileged or whatever, that is equity, but it ain't safety. So we have to be careful about the fact that we want everyone to be safe, and we want to take into account people who are most at risk, but be careful about buzzwords. Lastly, how to accelerate. I would suggest to you that the AHRQ safety culture survey be used in a different way than it has been. So the last time it came out, buried in that survey was that 30% of people surveyed did not believe that their hospital was committed to patient safety. Now, if that was an airline survey, that would be headlines everywhere. 30% of your airlines don't care. Instead, we bury this stuff because we accept a lack of commitment to zero harm as if it's normal. And so if you wish to use leverage, part of leverage is transparency. One last comment on transparency, and we can talk about that later off-site. And again, I've been writing and speaking in this too long. I put out a report with a colleague from Hopkins in 2014. Unfortunately, it didn't get a lot of attention because of Ebola. We looked at patient safety by congressional district, and we called it, "Are you in a safe congressional district?" A pun on that term. I would suggest to you that people do not care about their state, and they really don't even care about their county, despite all those nice public health people who've cared about that forever. They care about their locality. And putting things out by congressional district, all those indicators you have, would be a heck of a lot more effective for the real world than for health services researchers who want to look at it the other way. So put congressional district in there. We had to use GPS location data for hospitals and all the rest of that stuff, but that would help to be effective. And also, by the way, timely, right? Because Congress wants you to put out price data, which you do, but the price data would not be effective if the hospital said, you know what, this is 5-year-old price data, but it's comprehensive. So put together your data, have it be timely, have it be reliable, have it be salient to not just to researchers, God bless them all, I'm a member of Academy of Health, but also to the public and to members of Congress and policymakers and others, and journalists. So lastly, I wrote a piece years ago, How the Press Pushed the Profession. And if you take a look, the Harvard survey, the Harvard standards for anesthesiologists, all the way to everything else. It only happened because it got a lot of press and public attention. So I would urge you to remember that as much as you're working with people who are voluntarily doing things, and by the way, the literature shows how well that works, that you put out things in a way that helps transparency, helps get media attention, helps get the attention of all the really good people out there who need their leaders to pay more attention to patient safety and could use your help. So that's my short rant.
Michael,
Thanks,
I
Michael.
just want to very quickly, I can't respond to everything you said, but I just want to very quickly say that what you said is heard loud and clear. And I think all of the points that you mentioned, and I'm going to go back to my notes, we're talking about deeply at AHRQ, every single point that you mentioned. So we really appreciate you sharing that perspective because it's critically important.
And I'm happy to help offline. Of course, if I weren't an AHRQ fan, I wouldn't be here.
Awesome. Thank you for that. I was going to pull Kanan in to summarize group one, but then I think he dropped. So while we wait for him to come back on, unless someone else from group one can summarize, let's just go to Sherry because you had, there's Karen. Hold on, Sherry. Sorry. Hold, Kanan, why don't you jump in and give anything that's additive to what Kamal already summarized in terms of the question that was discussed in your group?
Sure. No, thank you, Edmond. I presume you can hear me okay, right?
Yes.
Okay, great. No, I think Kamal and our group did a fabulous job in summarizing things, and we pretty much covered most of what she ended up touching upon, but I'll just highlight a few things here. So for the first question, I think we started off by asking, what does actually engagement mean? And maybe trying to redefine engagement so that it's more focused on from a patient care perspective, and looking at it from a patient safety and quality of care point of view might be another way to redefine that. Similar to what we have from a customer journey map, maybe having a map for engagement journey would be another way to showcase the movement that you want to be seeing from an engagement piece of point of view was something else that our group highlighted there. And I think this was touched upon a little bit about collaborative learning, and this is where we want to make sure that by collaborating with the other systems and sharing experiences and best practices, this collaborative approach then can foster that community of learning, and then of course successes, challenges could potentially be shared. And I think if people were to see that, then you're probably going to be hoping to foster that engagement piece. I think this was touched upon by Kamal too, in terms of improvement in outcomes. That'd be another way to make sure we are engaging. And I'll also touch upon the aspect related to financial implications. And that's a strong motivator usually. And showing that whatever we are doing, whatever NAA is going to be doing, is going to actually help in lessening the financial burden might end up being a powerful motivator for folks to be wanting to be engaged as well. Yeah. And I'm just trying to go through the list to make sure I'm not missing other points that Kamal might have brought up there. To the second question, I think related to under-resourced healthcare provider organizations, I think the first point that we brought up was the fact of the importance of recognizing the struggles and barriers that these folks are going through, and in terms of both funding, staffing shortages, high patient demands, etc. And recognizing that would then be able to, one would be able to look at ways to promote that engagement piece. And I think the huge gap or missing factor out here would probably might be related to resources. And that includes financial, personnel, and time. And I think looking at it from these three big bucket point of view from a resource aspect might be another way to engage and motivate the under-resourced folks to be able to participate in this too. Creating incentives, forming learning collaboratives, demonstrating value are some of the other things. And the other aspect that we talked about related to under-resourced places is technology leverage. And able to leverage technology is going to be important, like the use of telehealth and artificial intelligence. The caveat out there is you don't want that to be an added tool for folks to do. Rather, it should, hopefully, if you're adding it, that it's going to either remove something else that they're doing or end up improving their workflow process, that ends up being a strong motivator for them to be able to participate and engage. The third question, we thought it was a tricky one, and I think Jade covered it in terms of what our thoughts were related to that. Because when you try to end up calling out a few folks to participate and not others, they're going to wonder why they weren't invited to be engaged as well. But I think if that's the path one is wanting to take, I think having a clear communication related to why a certain specific target organizations were chosen to help us start off with would be one aspect to go with. The second is, Peter brought this up in terms of pilot programs across different verticals, and I'll let him elaborate a little further on that. I think that was a good way to address the issue related to the tricky part of this particular question. And I think in the last, Deb mentioned that maybe to have an inclusive general call for participation, and based on who you end up getting, then I think it would be a good way to engage with the folks who are interested, and maybe interested, motivated folks to start off with might maybe show results that could then be potentially be extrapolated and are shared with other institutions to get their buy-in and subsequently their engagement to participate. So I'll stop there, Edmundo, and if time permits, if you're okay, I can just open it up to the remaining part of our group to see if there's anybody else who wants to add on to what I might have missed here.
Yeah, we can do that. Anyone else from that group that wants to add anything from what Keenan said? Cynthia, I see you.
Yeah. First of all, excellent work. I'm not sure you pronounce your name, Kanan or Canon, for the summary. I think the only other thing I wanted to underscore is that while it can be tricky to be targeting specific institutions, I do think that figuring out how we target certain kinds of institutions, and by that I don't mean necessarily like, directly reaching out to them, but making sure that in terms of the approaches and materials and tools that we might be that the group might be developing are designed with those groups in mind specifically, so they seem a bit more tailored and kind of easier to engage with. And then the last thing I would say is that I very much appreciate, can't remember the name of the person who was talking about, quality isn't free. Michael, thank you for raising all of that. I think that that there's a lot of alignment with concerns that you have shared, and also I think that it's important to communicate that designing a system or an approach based on the most challenging patients will give you a system that works better for everyone, right? So if you design, this is a principle in like accessible design, and it's a very explaining to healthcare entities that by focusing on the hardest cases, you are going to make things better for everybody and have better outcomes, will be a promising way forward. And I apologize for being so inarticulate. I'm struggling with a migraine and my words do not come easily. So thank you.
Well, thank you for powering through, Cynthia. We appreciate it. We just have a couple of minutes left in this section. Sherry, you've been hanging on like a trooper here, so I want to go to you.
Yeah. So just to say, to our art colleagues, thank you so much for this tremendous work. We over on the CMS side really view you as trusted partners, and we rely on the work to create the evidence that can be used for programs and policies, strategically thinking about which levers and the evidence should be applied towards. And just in case folks aren't tracking, Craig and team have been invited to speak at the CMS Quality Conference, which really is a large convening of ready to go quality improvement minded folks and communities. So I'm going to put that in the chat, but bottom line, thank you for the work. It's an honor to serve with you. Over.
Thank you, Sherry.
Thanks, Sherry. I see you, Mario, but Mary Beth was up, and I wanna pull you in if you had a comment and see if we can get you in before we go to Mario.
Sure. Thanks so much. This was a great presentation. I think what I wanted to share is what I perceive to be an opportunity, especially within the context of workforce safety and improving quality. What I would encourage us to consider is that collaborative learning and looking at the hardest models is our workforce design and our workforce patterns in terms of how we actually deliver care. Since the pandemic, it's been changing pretty dramatically, and we haven't really figured out where that should land best, whether it's inpatient, outpatient, nursing homes, the matrix of our clinicians, the availability of the different clinicians. It's changing and it's quite dynamic. And so part of that workforce safety for our clients, our patients, and our staff really has to do with this pretty rapidly evolving way in which we deliver care. The model is changing. And so if there's a way for us to explore and share success stories, I think that would be huge in terms of helping us understand safety for patients as well as clinicians. And I also think that needs to trickle back to schools. Colleges continue to train all clinicians on an old model that we're not using anymore. So I think we have an opportunity in this initiative to look at the way people are rethinking about how we deliver care and share those models so that it can be much more successful across the entire continuum of healthcare.
Thank you. Mario.
So health plans are influenced by quality bonuses, by HEDIS measures, by STAR scores, and they have the ability to influence both inpatient and outpatient care. One of the things to consider is for Medicare and for Medicaid agencies to write in requirements around healthcare and workforce safety into their contracts, both standards and measurements that have to be reported.
No, that's a good point and potential lever there. Peter, I did see you on for a second. If you have anything else to bring us home here on this section.
Yeah, it was just an additive comment to the two presentations, and not just to reinforce the potential for breaking down the different verticals across these pilots and to leverage the public-private types of convening functions or collaborative functions in here as well. And then the only other one was that we did express a little bit of concern about the evolving private equity presence in healthcare, and we're seeing not the best of outcomes related to those. And it gets to the comment that Mary Beth was just making. I think our environment's changing, our care environments are changing, our workforce is changing, our finances are changing. So how do we keep up with that pace and actually drive the pace as an entity that's funding different initiatives? So thank you for that brief moment.
Awesome. I appreciate that. Great. So let's and thanks for those comments. Let's we're still in this section around this topic, but we're going to shift over to Margie Schofer. So Margie's the director for the division of general patient safety for the Center for Quality Improvement and Patient Safety. Margie, you've got 18 minutes and not 20.
All right, thank you. So good afternoon, everyone. It's a pleasure to be with you today to discuss AHRQ's Diagnostic Safety Program. So just a roadmap for today. I'm going to provide a background on diagnostic safety, talk a little bit about our history of our work, And then I'm going to discuss our work as it relates to 4 core work areas: research, resources, implementation, data, and management, and then talk about future plans. And then I'm going to have some questions for you. Next slide, please. Oh, next slide. So first, I thought it would be helpful to provide a definition of diagnostic error for those who may not be as familiar with this area of research. So in 2015, the National Academies of Science, Engineering, and Medicine, NASM, published a report entitled Improving Diagnosis in Medicine. And that report defined diagnostic errors as the failure to establish an accurate and timely explanation of a patient's health problem or communicate that explanation to the patient. And it noted that research in this area hadn't gotten as much attention as that focused on errors related to treatment. As you can see, the statistics are concerning. It's estimated that approximately 12 million Americans a year will be impacted by a diagnostic error and can cause up to approximately 80,000 deaths in US hospitals per year. Next slide, please. So we've been funding research to improve diagnosis since we began funding patient safety research in 2000 after the NASM report to Errors Human came out. For example, starting in 2001, we funded Gordy Schiff's research that led to the development of the DEER taxonomy, which is a method to systematically evaluate diagnostic errors for each diagnostic process. In 2015, after the Improving Diagnosis report came out, we expanded our funding for diagnostic safety and quality improvement work, which I'll talk about next. We've also supported further development in the field. For example, we actually helped support the funding for the NASM report on improving diagnosis, and we've provided conference funding to the Society to Improve Diagnosis in Medicine, also known as SITM, starting with their very first meeting in 2008. Beginning in 2019, Congress appropriated dedicated funding for diagnostic safety. And so you can see that between 2019 and 21, we had $2 million a year for diagnostic safety work. In 22, we got an additional $8 million for a total of $10 million a year. And then in 23, we had an additional $10 million for a total of $20 million per year. Next slide, please. So let's start with research. Next slide, please. So after the Improving Diagnosis report came out, we supported our first 2 diagnostic safety specific Notice of Funding Opportunities, NOFOs. And between 2016 and 18, we were able to fund 4 grants. We had really hoped to receive more applications for this NOFO, but given that the field was still relatively new, we weren't really too surprised. As I mentioned, in 2019, our appropriations included $2 million for diagnostic safety research, and we used those funds to award 4 grants. We have had various diagnostic safety NOFOs posted since 22. That year, our NOFO was for the creation of Diagnostic Safety Centers of Excellence, which tackle a diagnostic safety issue, but also build the infrastructure to continue working in this space after grant funding ends. While the funding supported 8 grants for $1 million apiece, we had some additional grant funding available, so we were able to actually fund an additional 2 grants for a total of 10. In FY23, we funded 9 new diagnostic safety grants for $4.5 million, and in this fiscal year, we have a standing NOFO for this work, and our plan is to fund approximately 8 grants totaling approximately $3.2 million, and that includes grants for K awards for new investigators. Next slide, please. So this slide shows published papers from the 4 grantees we funded in 2019. All of those projects have ended. And in the interest of time, I'm not going to go over these, as we just released a blog on Tuesday about our diagnostic safety work that includes findings from these 4 grants. Next slide, please. So we recently awarded a contract to support learning and sharing amongst our diagnostic safety grantees with a special emphasis on our Diagnostic Safety Center of Excellence grantees, since we know those are a little bit different. The contract will also produce issue briefs that will summarize research to identify best practices, successful interventions, and gaps, opportunities for more research. Next slide, please. So following the NASM report, Senate report language in FY 2018 requested that AHRQ convene a cross-agency work group to address the lack of dedicated research into improving medical diagnosis, and in particular, diagnostic failures that lead to patient harm. The Federal Interagency Work Group on Improving Diagnostic Safety and Quality in Healthcare was convened by AHRQ in response to the Senate report. Members include representatives of HHS sister agencies such as CDC, CMS, FDA, IHS, NIH, ONC, which is represented by David Hunt, OASH, SAMHSA, and other agencies engaged in diagnostic safety work, such as DoD and VA. And we held our 15th meeting in March. And unrelated to the interagency work group, one more item under research is that we're very close to awarding a contract to NASM to support a workshop on reducing diagnostic inequities. Better understanding such inequities and identifying strategies to address them is an important research area for us. Next slide, please. All right, so let's talk about resources. And I just want to point out on this slide is a link to our diagnostic safety webpage. Next slide, please. So starting in 2019, we put a contract in place to develop several different diagnostic safety resources, including papers on different diagnostic safety topics written by experts in the field, including NAC member Kamal, who co-authored one of the 4 that you can see on this slide on maternal safety. The majority of these papers were published as AHRQ issue briefs, but some were published in peer review journals and made open access. So we now have 16 issue briefs and 6 peer-reviewed journal articles. And the issue briefs are categorized as either state of the science, a call to action, or an outlining of strategies to address a particular topic. And roughly, they sort of fall under the following areas: measurement and reporting of a diagnostic error, cognition, clinical reason, education and training, system design and teamwork, specific populations, patient and family engagement, and technology. Next slide, please. So the contract I just mentioned also developed 4 different diagnostic safety resources. Our toolkit to engage patients to improve diagnostic safety is based on research that suggests that patients are interrupted by their providers within the first 11 to 18 seconds of telling their diagnostic story. Now, there's really good reasons for the interruption. Providers are busy and don't have a lot of time, and sometimes patients don't know the most helpful information to share. So our resource addresses this issue. Be the expert on you is for patients and helps them to prepare their personal health story in a clear, concise way. And then 60 seconds to improve diagnostic safety prepares providers to practice deep and reflective listening for 1 uninterrupted minute at the start of a patient encounter. Next slide, please. As the saying goes, you can't improve what you don't measure. So we developed a resource to help organizations learn about diagnostic safety events. It's meant to be used by any organization, those that are new to the area of learning from diagnostic safety events, and those who've done some work in this area. And there's 4 strategies included: using safety and quality data already collected by the organization, soliciting reports from clinicians and staff, leveraging patient-reported data, and electronic health record enhanced chart review. Next slide, please. Calibration is defined as the better alignment between the clinician's confidence in their diagnostic performance and their actual performance. So this resource provides clinicians with guidance for evaluating and calibrating diagnostic performance for the purposes of learning and improvement. And it's one of the resources that Craig had mentioned in his slides. Next slide, please. You may be familiar with Team Steps, our teamwork and communication training curriculum. And we decided to develop a version that is specifically focused on communication to improve diagnostic safety. So I'm really excited that the word has gotten out about our resources. We've been presenting them at in-person meetings, such as CITM, IHI, Academy Health, and it's paying off. So for example, the Leapfrog Group has them listed on their website. The Doctors Company, which is a med malpractice provider, links to them. And I just saw that ECRI referenced at least 2 of our resources in their top 10 patient safety concerns of 2024 as tools to address 1 or more areas of concern. And I haven't fully gone through that report yet, so there might be more in there. And then another example is that the issue brief I referenced that was written by Kamal served as the genesis for a NASM workshop on diagnostic excellence in maternal health. Next slide, please. All right, so now I'll talk about implementation. Next slide. So Craig mentioned this in this presentation that we plan to implement and evaluate the impact of the 4 resources I just mentioned in approximately 50 to 60 healthcare organizations. And then we're also going to work with those healthcare organizations to sustain the changes that were made. Our recruitment will soon be starting for the implementing Team Steps for diagnosis improvement curriculum, and recruitment for the other 3 resources will be happening in later fall this year. Next slide, please. All right, so finally, let's discuss what we're doing with respect to data measurement. Next slide, please. The common formats for event reporting diagnostic safety is intended to facilitate the collection of a basic set of meaningful data about diagnostic safety events that can be aggregated and analyzed for learning and improvement at the local, regional, and national levels. And as with all common formats, available in the public domain. Next slide, please. As you may know, AHRQ supports the surveys on patient safety culture, and we developed a diagnostic safety supplemental item set for the office-based survey. The supplemental item set was designed to help medical offices assess the extent to which their organization's culture supports the diagnostic process, accurate diagnoses, and communication around diagnoses. Next slide, please. And this is just an example of some of the questions. Next slide, please. So I'm really happy to share that we recently hired Karen Cosby to take over my role in leading the diagnostic safety program. Karen most recently was the program director of the Diagnostic Excellence Initiative at the Gordon Betty Moore Foundation, and she has over 30 years experience working as an emergency medicine physician. Karen's going to be helping develop a 3 to 5 year plan for moving the field forward. You know, while we're really appreciative of $20 million a year we get in our annual appropriation for this work, we're also going to plan for any increase of funding that we may see in the future. And, you know, part of our planning for the future includes addressing emerging issues like in diagnostic safety, such as AI. Another essential activity of this work is collaborating with others in the space. We know it's important that we complement, not duplicate the work of others. So in addition to federal agencies, we're also in contact with leaders of the Leapfrog Group, NASM, Academy Health, IHI, the Council of Medical Specialties, the Doctors Company, and a new Diagnostic Safety Coordinating Center out of UCSF, among others. And we look forward to continuing our collaboration with these and other diagnostic safety focus groups. Next slide. So now our questions for you all. So what do you see as the biggest needs related to improving diagnostic safety? And are there any additional areas we should be investing in as we grow the program?
Well, first, thanks, Margie, for that overview. Very efficiently done. So I certainly appreciate that. And yeah, let's open it up for folks. And I see Cincy and Kamal. I'm going to expect you to jump in since I know you're close to this work. So I'm just going to call that out now. But Cincy, go ahead and go first.
Hi, yes. Thank you so much for this presentation. I think there are two areas that I really want to highlight. And one of them is which you raised about how patients are not given a respectful opportunity to really talk about what their situation is when it comes to talking to their providers. And worse than that is even when they do raise their concerns, we know that so much of what happens when it comes to health inequities for people of color and especially women of color is, it's not because the person did not raise a concern. It was because that concern was ignored. And, you can look at, we work a lot on maternal health. And so maternal health is a huge area where we know this is a case. And, doesn't matter how much money you have or how well known you are, like, anyone can look up Serena Williams' story and understand that the fact that patients are actually the experts of their own bodies is constantly ignored by the medical establishment. And I can say there've been several times in my life where I've almost died despite me and people with me raising an issue and being completely ignored and minimized. Oh no, you're shivering not because you have 104-degree fever, but because you're under the air conditioning vent. True story that happened to me in a hospital in Florida. Being sent home septic, being sent home with preeclampsia from the hospital, all these things are experiences that I've had. And as a consumer advocacy organization rep, I think it's really important that in meetings like this, we do raise the human side and the human cost of these issues. And so that leads me to my second question, which is in terms of where there's huge need and is I think in the area of maternal health. And so my question would be, how can we kind of prioritize these challenges, especially in the maternal health space, especially given, this crisis that's getting worse on a yearly basis for everyone, but especially also for women of color.
So, so first of all, I couldn't agree with you more. I mean, the patient is the one like I usually say, the patient is the one constant in their journey, right? I mean, no one knows. Lots of people come in and out, but the patient is the one constant. I mean, there's so many with diagnostic safety, and the field is still relatively new. There's so many different, different priorities for us to focus on. I mean, improving maternal health is definitely one of them. And in a sort of separate part of our, we recently updated a perinatal safety toolkit that we had available a while ago, and it recently got updated. And as I said, Kamal wrote an issue brief on improving maternal morbidity and mortality, which then got translated into a NASM workshop. So it definitely is a topic area that is important to us. So thank you for sharing your comments.
Yeah, thanks for that question and your response, Margie. Peter, I see you, but I actually want to pull in Mason. So does this concept of diagnostic, kind of efficacy and error, does that raise the level of epidemiology? Is this occurring to you? Are you thinking about this? And if you are, how are you thinking about this topic that is being covered here?
It does. I would say some of our most common examples recently are infectious diseases. Some of the paradigms of diagnosing various diseases such as HIV shift, but then also are open to interpretation by the provider and those health administrators such as infection control, et cetera. So we certainly want to work to improve that. And I think that falls into the line of epidemiology, because if we don't improve that diagnostic capability or that knowledge base, then we just continue to see those disease trends up. So, I think it does play an important role in it.
Mm-hmm. Awesome. Thank you for that. Let's go to Peter.
Yeah, thanks so much. Great presentation. It's an interesting one because we've got a few different recently aware evolving areas that need to be brought together. So there's the diagnostic errors, there's the evolving arena of apology, disclosure, transparency. There's the evolving area of the second victim, the person who was involved in that, and that also impacts into workforce wellness and anxiety, burnout, workforce safety, if you will. So it'll be interesting as these areas move along, how can we better overlap them so we leverage it and not just wind up siloed in each of these intellectual areas evolving independently.
Yeah, no, that's a great call out. And where do those threads, where can you pull those threads all the way through? And thematically, that's great. I'm gonna again call an audible here. Gina, I really want to think about, like, how are you thinking about this? This falls, I think, loosely into your scope, or maybe tightly into your scope, but from a payer perspective, how are you thinking about it at Horizon Blue Cross in terms of these topics?
Yeah, I'm just thinking, in tying it into the earlier topic, what role does AI play in terms of improving diagnostic safety? I think there might be opportunity there to really research into that topic so that we can understand better, because AI is definitely exploding on the payer side. We are meeting with vendors almost on a daily basis that have different capabilities, and a lot of them include AI technology. So I think understanding how AI can play a big part in improving diagnostic safety is kind of what I've been thinking about as I'm hearing these fantastic presentations. Thank you so much. Such critical topics, but that's kind of where my mind has been going in terms of the work that we're focused.
I think you and many others, this is very much a trending and relevant topic here. Michael, let's go to you.
So I did a study, for a great presentation. I did a study a few years ago with Hardeep Singh on the evidence base on direct-to-consumer diagnostics. And the evidence base was not only sparse, but the studies were lousy mostly. And frankly, they were mostly doctors doing studies and saying, is the diagnosis as good as me? Nope, I'm smarter than the app. Great. I'm happy to hear that, except that that's not really what patients are always using it for. And then you have the explosion of AI. So both asking a chatbot a question, but also AI-powered apps. So certainly there's diagnostic error and diagnostic accuracy that are outside the traditional healthcare system, which is what CITM, which I've been involved with, was looking at when they first started. And with that, what we now have, the symptom checkers, were not very good because there tend to be multiple choice. But now we have the evolution of smartphone sensors, which have tremendous diagnostic accuracy in some cases. So I would urge you all to really try to get ahead of that. And frankly, a lot of the research is also not very good in the sense that, you know how doctors are criticized for cut and paste with EHR? Well, PhDs, when you cut and paste evaluations of technology that are 10 years old and you throw them into your footnotes, all you're doing is misleading people. And I would urge AHRQ to try to get better rigor in some of what's published on this, because this is a huge exploding area and it's happening and we need to get the research. Last point, since you all work with FDA. FDA, with all due respect, has done understandably a lousy job on the direct-to-consumer side, because that's not where their focus is. So here you put out an app that's supposed to diagnose your skin cancer, but you put on the app not for medical purposes. And so therefore, boom, you don't need any regulation, because who doesn't try to diagnose their skin cancer for amusement on a Saturday night? So I would suggest that FDA start to get a little more realistic while they're looking at the healthcare system. What are they going to do with some of these others as well? So perhaps you can have a dialogue there.
Yeah, no, that's a really good call out, and it actually goes to another theme that we've discussed in previous meetings, which is that there's just sparse efficacy data on digital tools at large. Right. And so, but they're getting out there, they're getting funding from investors, and they're even exiting at unicorn multiples, literally, with no data to support that they actually are efficacious in a clinical setting. And so, again, what's the role of AHRQ in stepping in and providing some bulwark around actual true clinical efficacy as these digital tools continue to proliferate? I think that's a really, really good call out. Before I get to you, Al, I wanted to pull Kamal in and ask, why jump into the work of writing an issue brief around this and around this topic? And obviously it's your clinical specialty, but what kind of inspired that work and led you to that?
Yeah, thanks for that. I just am so appreciating this conversation, and congratulations to Margie and the whole team. What Margie's saying about sort of the uptake of all of these wonderful tools and ideas is really, really true in areas that you sometimes don't even expect. So it's just wonderful to see. I think, Edmondo, to your question, I am not a native to diagnostic excellence, right? As a quality and safety leader now for several years, right? It wasn't something that I had sort of picked up initially, but as I learned more about it, as the National Academies came out with a report in 2015, it was clear, right, that it sort of helped put words to a lot of these ideas and concepts that were sort of missing and needed to be addressed. And so that's why I think I was sort of drawn to it. And certainly, since he mentioned, maternal health absolutely needs to be one area. I think mental health is another. Sort of specialty population. But as it relates to kind of some of the more, things sort of in the future, there's a lot and necessarily on what happens when someone enters sort of healthcare, but this, sort of what are evidence-based ways to shorten the time it takes from when a patient has a symptom to accessing the system. And that obviously means that they have to understand that that is a symptom, recognize it as something that needs sort of evaluation, trust and believe that the health system will help them, right? And then get to the right place, right? And so that whole sort of pre area, I think, is something ripe for innovation and understanding. And that also ties nicely to what Margie highlighted, which is diagnostic equity. I think in understanding that a little, sort of characterizing those opportunities better will hopefully lend it to solutions. I also think, how misinformation contributes to diagnostic errors is an interesting area. And then I will throw this out there as provocative. How does climate change impact diagnostic errors? I'm just conjuring the example of, air quality in New York. We have seen some very interesting things as it relates to diagnosis during that period. And I think there's a lot of sort of opportunity there. So thank you for highlighting my very microscopic piece of work in this large ocean.
It was wonderful. And I'll tell you on that last point, well, as someone who grew up in the Valley in Los Angeles in the 80s, and wondering why I couldn't breathe, I can absolutely tell you that there's a there that we should probably explore and be exploring more. Al.
Thank you, Armando. First, Michael, when I see you in person, I want to have coffee with you because I love the things that you're saying and want to echo the same thing. I've been sitting here and first, Margie, great presentation. I've just been sitting here and thinking, how does pharmacists fit into this space? And I think being the last person to interact with the patient in many ways when dispensing medication, is there a way, how can we catch some of this, and because is it diagnosis errors, is it related to medication, or is it related to something else? And so I'm just I'm trying to rack my brain, and I agree with Peter. I think part of this is removing those silos, and I think you will get that complete picture. How we get there is where I'm trying to figure out or just think about what does that space look like, and utilizing all the digital tools that we have, and knowing that we're now seeing direct-to-consumer prescriptions with, Merck, Eli Lilly, and what have you. And how does the FDA stand up and interact in this? Because that's outside of the hands of many boards of medicine and boards of pharmacy and boards of nursing. But if there are any ideas, I would love to hear them, because I'm open ears to seeing how we can interact in that space moving forward.
And I'm happy to say we have a pharmacist on a PharmD on the team. So I will definitely be taking your question or her so we can noodle on it a little bit more. Thank you.
Yeah, great. Yeah, great call out. It looks like I saw you, Peter jumped in.
Sorry, I just want to build off that and to recognize that a number of clinical disciplines separate from physicians are, elevating their training. They're trying to get higher levels of responsibility with their licenses, and different states are allowing those different levels of responsibility with their licenses to occur. So the decision-making and the diagnosing is going to start to happen not just with physicians, which is where this has all started. So we need to be prepared for that future eventuality, which is already on our horizon.
Yeah, no, very, very true. As a matter of fact, I would argue that current scope of practice already allows a lot of this activity. We just haven't allowed folks to practice at the top of that license.
Yes, and ideally, I'm a nurse, and when I was taught, we were always taught nurses don't make diagnoses, but nurses can be engaged in the diagnostic process, right? So really, there's an opportunity for everybody to be engaged in this process.
Absolutely. Very, very rich conversation. Thanks to the team for setting up, to Craig and Margie, and for setting up the conversation so that the NAC could engage so well. And thanks, Chief, for jumping in as well on some of the comments. Appreciate all that. Really good conversation. I do want to call out, and I'm gonna scroll back up on my comments because again, if it's in the chat but it doesn't get talked about, it's not real, right? It's like if you don't document it, it didn't happen, right? So it's one of those things where if it's in the chat but it didn't get called out. So I want to pull a couple things out of the chat that are going back a little bit, but are loosely kind of in this vein. One of them was that one person mentioned considering adding PSO leadership and risk management malpractice organizations to the conversation around quality safety. Another suggestion, this came from Michael, was to consider adding input from vendors of patient safety products and services to the conversation as well. I think that's a really interesting one. And again, it may actually go, that part of the conversation may go both in hospital, but also outside of a hospital. And then I think that was the bulk of the actual content that came in on the comments, but on the chat. But I wanted to pull those into the conversation. Anything else on this topic before we close out? We're a couple minutes over, but I think we're okay. Go ahead, Liz. She's having trouble. That's okay. When you figure it out, we'll pull you back in. But she's having a little trouble with her sounds with her mic. So why don't we? So thanks to the team again, Craig and Jade and Margie for that. We're going to move to our next topic here, which is actually public comment. So if I have this correct on my last minute. Here, we have Akira Zorek, Wizarek. I'm sorry if I mispronounced your name, from AHRQ. I'm going to jump in on public comment. Just going to give her a second to pull her into the conversation.
Hi, can you hear me?
Yep, we can.
Okay. Yeah, it moved me into a panelist. It took a couple seconds, so thank you. And thank you for the opportunity to be here today. I am here with AHRQ, on behalf of AHRQ. We're an independent nonprofit patient safety organization. And I'd like to comment on something that others have commented on, which is the ongoing health crisis in the United States, the lack of quality, accessible maternal and perinatal care. AHRQ's mission is to advance evidence-based healthcare worldwide. We see these barriers to care as a critical health equity issue. The U.S. maternal mortality rate is ranked the world's worst among affluent countries. We're seeing alarming rates of preventable maternal deaths. About 1,200 patients die annually, and another 50,000 suffer pregnancy-related complications or severe morbidity. And limited access to obstetric and reproductive care disproportionately harms women of color. So we here at AHRQ, we work with the Health Resources and Services Administration to provide resources, education, and tools on maternal safety to all federally qualified health centers nationwide. About 2.2 million women of reproductive age in the US live in maternity care deserts, which are areas with no hospitals providing obstetric care, no birth centers, no OBGYN providers, and no certified nurse midwives. So FQHCs and other community health centers, particularly those in those remote areas, are a key aspect in improving access to high quality care for medically underserved patients. In our work with AHRQ's federal partners and with thousands of providers in those maternity care deserts, we've seen how this health crisis is impacting patients' lives. Patients who don't have access to a hospital or emergency department, and those who don't want to go due to cost or their immigration status, end up seeking urgent care for complications in community health centers or free clinics. Or worse, with nowhere else to turn, patients get false information about health issues like contraception from social media. So this week, AHRQ released our top 10 patient safety concerns for 2024. We identified barriers in access to maternal and perinatal care as the number 3 safety concern. Our report includes recommended strategies to improve access and care, including advocating for public policies that expand insurance coverage, reimbursements for maternal care programs, and obstetric workforce initiatives. AHRQ supports efforts at the national level to increase access to women's healthcare services and address preventable maternal and infant deaths and complications. We ask AHRQ to prioritize funding and research to ensure that all patients across the country have access to safe, affordable maternal and perinatal healthcare. Thank you.
Thank you. All right, that is, yes, that is all, that is the only public comment that we have for today. So that closes out that section of our agenda. Now we get to move to the chair's wrap up. So first thing I want to do as part of the chair's wrap up is really thanks to the AHRQ staff, one for organizing the meeting and all the technical kind of hurdles that need to be jumped through when you've got the pre-meeting sessions, the actual session itself, getting folks in and all that. Really appreciate the staff, as well as to our director, Bob Valdez, Karen Rhodes, Chris Dymek, Ed Lowiton, Craig Umshade, Jade Purdue-Pulley, and Margie Schofer for their presentations. Really great, really engaging. And look, I understand, like, the staff. Like, I just have to say this. I know it's really hard to set up the conversation so that the NAC is engaged and are going to give you back, kind of great comments, questions, and really kind of further. That takes work. And so I really appreciate the time and effort that the staff puts in to set us up so that we have really rich conversation. You guys did a really good job today, and I wanted to commend you on that. What I'm going to do for my my kind of wrap up is a quick summary. But what I'm going to do is I'm going to call out the new NAC members. And I'm going to ask you to share with the group one thing you've had your almost complete first meeting. So one thing that you would like to accomplish during your time as a NAC member. I'm going to give you, you're going to have about 30 seconds to think about it, then I'm going to start calling on folks. But I give you 30 seconds. One thing you would like to accomplish, and that could be, maybe it's a personal thing, or maybe a personal knowledge thing, maybe it's something you want to engage in, maybe it's a specific goal that you had, or maybe it's knowledge sharing back to the larger group. But for the new members on the NAC, be thinking about one thing you want to accomplish during your term. For my summary here, I mean, what a great meeting. It's always for me, I really like being in person. There's something in the air. There's something going on. You could have coffee with Michael, those kind of things when you're actually in person. But I have to say, this was a really good meeting. Always well launched by the director's update, which again, really appreciate what you brought to the table here, Bob. It's the PCOR Trust Fund snack and the recommendations. Great work there. Love the summary. Love the actual work that was done, and I was able to kind of read through all the minutes and really feel good about supporting those recommendations and moving that work forward. Of course, we spent time on digital, and that's my area, certainly my area of interest. And I thought it was a really rich conversation that crossed a broad swath of digital health. And I think that's appropriate, because I think digital is really going to be touching every aspect of what we do in healthcare. And AHRQ has been leading the way in helping us understand that for quite some time. And then we went into this the safety, diagnostic excellence, and all of those things, diagnostic errors. And again, very critical for how we actually deliver health, and not just healthcare, but how we deliver health, and then AHRQ's role in helping us get there. So really great meeting, and again, really appreciate everyone's engagement around that. Before I start to go to new NAC members, Liz, if you're back up on audio, I want to pull you back in. Let's see what she's got there. She's got a headphone. She's got the whole setup now.
Hello, this is Carrie Levy. Can you hear me?
It's who Who's that?
Carrie Levy's on the phone.
Oh,
Oh,
Carrie,
it's Carrie. Okay, Carrie's on. Okay, I couldn't tell it was Carrie. I just saw a phone number.
Oh, I'm so sorry. Did you want me to speak or shall I hold a moment?
Just hold a moment. But I will call on you, so like don't go too far.
Okay, can you hear me now?
Yes, Liz, we got you.
Wow, I'm so sorry. It's definitely on my end. I will QA this problem later, but I just wanted to say on the PSO issue that was brought up on chat, I just wanted to encourage Craig to think about using PSO as a vehicle, perhaps to get folks more comfortable and as a carrot to come to the table for the Action Alliance. And ditto on the malpractice in our area. Our malpractice premiums are reduced when we do certain things. So just thinking about how to sprinkle carrots around this implementation. That was probably a long run for a short slide, but Armando, thank you for pulling me in. And sorry for the inconvenience.
All good. Thanks, Liz. All right, so we're going to go through, and Carrie, I don't know if you heard my prompt for the new NAC members, but it is okay. Great. So wonderful, because you're first.
Okay, great. So the thing that I appreciate the conversation so much, and we've had off and on power all day with the snow, so I apologize. But I've really enjoyed the conversation and thought deeply about how to, help move things forward. And I think that the thing I'm hoping to accomplish is to keep long-term care in the conversation. It's such a unique environment, but faces all the same challenges as as each of the, acute care and all the different areas we've talked about. So my hope is to make sure that I'm helping translate for the field and also for this group, the things that we face related to digital health and safety and equity. So that is my charge for myself.
Awesome. I appreciate that. I appreciate that charge. I see Michael next.
Well, first I want to say, Armando, that I go to a lot of meetings with everyone here, and my God, do you do an awesome job of running this? I've actually, I'm going to be honest here. I Googled you to say, this guy is so good. Am I sure that he's like in front of this thing? That just, when this whole doctoring thing doesn't work out, you've got a different career here. Just two things. One, for me, as someone who's self-employed, the fact that I can learn regularly from colleagues is really important to me, and that's sort of an accomplishment. And the second thing is, the only reason any of us are in this is to change care for patients. And so for me, if I can interact with staff and colleagues and cause folks to make greater progress at being more effective in what they're trying to do anyway, that's the reason we all do this. So that's really what I hope to do. And as I said, I've been a fan of AHRQ since its inception. And so to work with colleagues here and with AHRQ is a great opportunity to, maybe push progress just a tad faster than healthcare ordinarily goes.
Awesome. That's great. Thanks for that, Michael. Peter, I see you.
Yeah, thank you so much. It's been a terrific meeting, and it certainly exceeded my hopes and expectations. So thank you so much. I'll kind of go in the same direction Mike just went, and that is, at the end of the day, we're all here with an altruistic drive to really create larger scale change in healthcare. And so, and yet our environment, our industry is different. And as I view it, the only way we're going to reach those aspirations is for stronger levels of collaboration and really to leverage each of our platforms so we can collaborate and create this change that we all aspire to.
Mm-hmm. Awesome. Great charge for all of us, really. Mason.
Thank you, Armando. I'll echo what everyone else has mentioned so far. It's been a great meeting, very insightful and great topics to discuss. One of the goals that I have during my term is to bring to light some of the healthcare inequities or challenges we're facing in rural America and Indian country, and to help collaborate with everyone on how we can improve that healthcare delivery to our patients, whether they be a direct care model or if it be within the clinic walls. We just have to do better so that they get the care they deserve. just as their opening counterparts.
No, that's thank you for highlighting that, Mason, and we will keep that highlighted as we go through. And, you know, I think it was Michael who mentioned earlier the various aspects and components of what equity could look like, right? And so we can't leave rural out of that. You know, I'm in Florida. Florida, of course, they think of like Miami, maybe Tampa, which is where I am. But I take care of patients that are driving 3 or 4 hours, you know, and live in rural Florida. And I always, whenever I take, and I'm a hospitalist, whenever I'm seeing these patients in the hospital, whenever I'm taking care of them, I'm like, great to take care of this patient, but I'm thinking, who did I not see because they couldn't make the drive, right? And that always just bothers me. Like, who am I missing because they couldn't drive the 3 hours it took them to get to Tampa? And so I definitely want to keep that in mind, Mason, and appreciate that. Mary Beth, you're up.
Yeah, ditto. I mean, it's really been an amazing meeting, so thank you for that. I think I've got 2 thoughts. One really has to do with our clinical decision support and trying to move that to that predictive model, if possible, because I do think if we can do that as we implement those, that's actually going to help us with not only patient safety, but also worker safety because of the advanced thinking and the way those models are going to be more predictive rather than reactive. And then I think the other thing that came to mind for me has to do with the fact that as rapidly as healthcare is changing, how do we use some of the amazing tools and resources that AHRQ has put out that we heard about today and get those into the systems that are training the next generation of healthcare clinicians so that they're coming out actually engaged and able to participate in those systems more actively, both as a student across all venues, but also meaningful employees and clinicians, all clinicians across the entire healthcare spectrum. So we're advancing that implementation faster because they're aware of it rather than learning about it after the fact, if you will.
After the fact, yeah. Yeah, no, absolutely. No, that's exactly spot on. Thank you for that, Mary Beth. Mario. No, can't hear you. Are you on mute on your phone? Maybe put your phone. Yeah, there you go.
Can you
got
hear
you.
me? Okay, good. So I'm very interested in innovative delivery of care models, how they could increase the quality of care at the same time decreasing the cost. As we embrace value-based care, we've gotten very good at knowing what the cost of something is, but we're not very good at measuring the quality or the outcomes. So to really do value-based care, we have to really understand what the outcomes are and how do we measure those things. Came up on the call today, private equity investment in healthcare and many vendors that are coming up with new solutions. And I saw a lot of this when I was running a health plan, and frequently there's no data behind it. Someone will come in and tell you they've got a brand new product that's going to do great things, or someone who has some initiative, but there's no data behind it to show that it really is effective. And I think we need to be very disciplined about looking at the data. The final comment is on the whole issue about diagnostic errors is very interesting. You know, as a physician, I know how difficult it is to make a diagnosis. It's a very squishy thing. It's rarely cut and dried. So I'm interested in learning more about that.
That's great. Squishy is one way to describe our work. That is exactly right. Where did I leave off? Sunil.
Yeah, Edmond, I want to echo earlier comments about your moderation. I learned so much from this meeting. It was such an engaging format as well, and look forward to being part of the group. As a new member, I feel like I have a deeper appreciation for AHRQ's investment areas than I had before, and especially appreciate the importance of partnerships in carrying out AHRQ's mission. You know, I mean, as I've seen the organization, you know, perennially have challenges with, you know, having a fixed amount of funding and the PCOR trust fund needing to be reappropriated every several years. It's hard to carry out these bold missions without effective partnerships. So for my part as a member, I mean, I'm hoping to play some small role in contributing to the development of more enduring infrastructure. If there are AHRQ programs and partnerships that can help our health systems develop that infrastructure around a learning health system, particularly to continually reassess our practices and carry out change and be motivated to do so for multiple angles. I think that would be a tremendous way to leverage AHRQ to leverage its resources and partnerships. And in particular, I hope that we can see our health systems continue to evolve to provide that evidence-based care across the full continuum of the patient and family experience. And so often the work is in the hospital setting or in the primary care setting or in the emergency department setting without the effective incorporation of multiple sites of care that represent the patient's journey. So when crafting funding announcements, I know that's hard, but I think that's where we're going to achieve a lot of positive, enduring change. So look forward to being part of that.
Thank you, Sunil. If I'm not mistaken, I think Sharon brings us home.
Yes, okay. It's always hard to be the last person. But I mean, this has been a great meeting for me. I've learned a lot about the different programming that's going on. Liz, I just want to say I appreciate your comments about pulling in the PSOs into some of this. I think there's a lot of opportunity using the protections under the Act. It's not that long ago I was system leader in a large healthcare system in South Carolina, you'll hear me use the words a lot about connecting the dots. So Sunil, it kind of runs into what you're saying too, is how do we connect the dots between safety, quality, financial, being mindful of the finances on this side. I'm very passionate about looking at this work across the balanced scorecard. I failed to mention in my intro that I also teach a human factors and healthcare class at Auburn. And I do think that there's some opportunities, not just in the human factors and devices, but human factors in the design of a process. So I'm looking forward to being more involved. Very, very interested in the National Action Alliance for Patient Safety and Workforce Safety. That's very much a passion of mine. So thank you.
Thank you, Sharon. Did I miss any of the 8 new NAC members? I don't think I did. So unless we have a poetic summary to end the meeting, I will entertain a motion to adjourn.
So moved.
It's moved and second.
Second.
Moved and seconded. With that, I'm going to take that as consensus that we are adjourned. Thank you, everyone, for a fabulous meeting.
Thank you. Well done.
Thanks so much. Well done, Stoll.